Now I invite the chairpersons for this session, Dr. Amarnath sir, Dr. Pari Vijay Raghavan, who is the transplant surgeon at KMCH, Dr. Arulraj Ramakrishnan, is hepatologist at KMCH, Dr. Madhusudan, and Dr. Pankaj Sharma. I request all the chairpersons to be on stage. So they will be moderating session by Dr. Avinash, who will be speaking on mass forming pancreatitis versus pancreatic adenocarcinoma. Dr. Avinash is the chief of abdominal radiology from Brigham and Women's Hospital, MGH.
Oh, perfect. Okay, thank you again for the kind introduction. It's a real pleasure to be here. Okay, I hope I don't put you guys to sleep after a great lunch. So I'm going to talk about mass forming pancreatitis and pancreatic cancer. These are my disclosures. So what I plan to do is start off with discussing the imaging manifestation of pancreatic cancer and then describe the imaging features of the common inflammatory mimics of pancreatic cancer and also review the differentiating features of pancreatic cancers versus benign inflammatory masses. Now what I've done here is, though my topic was mass forming pancreatitis versus pancreatic cancer, I'm trying to include other inflammatory mimics. So when you talk about mass forming pancreatitis, we typically refer to mass forming chronic pancreatitis, but I've also included autoimmune pancreatitis and paraduodenal pancreatitis, which we sometimes have difficulty differentiating from pancreatic cancer. So those are the four different topics I plan to cover today. So I'm going to start off with pancreatic cancer. Now, pancreatic cancer or ductal adenocarcinoma is a tumor arising from the exocrine pancreatic ductal system. It's now the third most common cause of cancer mortality in the United States. In 2024 alone, nearly 66,000 new cases and 51,000 deaths were estimated due to this disease. Now, this tumor has an aggressive biology, and patients often present late due to complex regional anatomy and lack of reliable tumor markers. Imaging has an integral role to play in the diagnosis and staging of patients with pancreatic cancer. Let's directly move on to the diagnosis and the imaging manifestations of pancreatic cancer. Now, pancreatic cancers often manifest as hypodense infiltrative tumors, often affecting the pancreatic head, and these cause varying obstruction of the pancreatic ductal system as well as infiltration of the adjacent vascular structures. So for example, if you see on the lesion here in the region of the head and uncinate process, you can see the narrowing of the superior mesenteric vein. Similarly, on the image on the right, you see there's narrowing of the superior mesenteric vein by the mass in the uncinate process. Double duct sign is a pathognomonic imaging manifestation of pancreatic cancer where you see obstruction of the biliary system and the pancreatic duct, and this double duct sign is manifested and depicted well on MRCP images. So if you see on your extreme right, you see a double duct sign on an MRCP where you see a pancreatic head mass causing pancreatic ductal and biliary ductal dilatation. Body tumors which affect the pancreatic body, as you can see in the two images here, often cause upstream ductal dilatation and atrophy of the tail of the pancreas. Now, one of the uncommon manifestations of pancreatic cancer is isoattenuating tumors, which cause pancreatic ductal obstruction. And these tumors, as you can see in the images here, are often difficult to diagnose. But the things which help you diagnose include contour deformity, vascular involvement, and duct cutoff sign. I want to emphasize on duct cutoff sign here because duct cutoff sign is one of the early manifestations of pancreatic cancer where the tumor obstructs the pancreatic duct and all you see on imaging is a dilated pancreatic duct which has abrupt cutoff. So when you see a pancreatic duct cutoff on imaging, it's important to aggressively interrogate the site of transition to identify small pancreatic tumors. The reason you want to identify the duct cutoff sign and the site of obstruction is because if you look at the natural progression of pancreatic cancer, the duct cutoff sign is often the early manifestation of pancreatic cancer, and given that surgical resection is often the curative treatment option in pancreatic cancer, which has a very poor 5-year survival rate, identification of tumor at this early sign is extremely important. Okay, so with that, let's move on to other inflammatory conditions which can mimic pancreatic cancer. So I'm going to start with mass forming pancreatitis. Now, mass-forming pancreatitis is a form of chronic pancreatitis, and nearly 27 to 50% of patients with chronic pancreatitis manifest as a focal mass. Now, chronic pancreatitis occurs due to repeated pancreatic inflammation, which leads to parenchymal fibrosis and glandular atrophy. This leads to both exocrine and endocrine dysfunction. So patients often present with diabetes and manifestations of exocrine dysfunction like malabsorption and steatorrhea, and manifestations clinically include abdominal pain, weight loss, nausea, and jaundice. Now, there are different etiologies, but what we typically see for chronic pancreatitis include alcoholic pancreatitis and pancreatitis related to tropical pancreatitis, which I think is more commonly seen in the Asian subcontinent, and due to other rare causes of chronic pancreatitis. If you look at the imaging manifestations of chronic pancreatitis, typically there are three cardinal features. One is pancreatic calcifications, both parenchymal as well as pancreatic ductal calcifications. You can see in the top CT image, there are multiple calcifications scattered throughout the parenchyma as well as in the pancreatic duct. These stones can cause pancreatic ductal dilatation, and the pancreatic ductal dilatation can also occur secondary to fibrosis of the pancreatic duct due to repeated inflammation. Now, in the parenchyma, majority of patients with chronic pancreatitis have atrophy, but normal or enlarged pancreas can be seen in 15 to 20% of cases. On MRI, because pancreas typically has a high signal intensity in normal cases, the normal high signal intensity on T1 weighted images is replaced by low signal intensity. So what happens in mass-forming chronic pancreatitis? Now, mass-forming chronic pancreatitis, as I mentioned, occurs in 27 to 50% of cases. They are typically located in the head of the pancreas, and these often manifest similar to pancreatic ductal adenocarcinoma. Hypodense masses, hypoattenuating, causing peripancreatic infiltration. They can cause pancreatic ductal dilatation. They can cause pancreatic ductal strictures. But as these mass-forming chronic pancreatitis occur against a background of chronic pancreatitis, you also see pancreatic parenchymal calcifications. So these are two images in patients with mass-forming chronic pancreatitis in the head of the pancreas, as well as this another example where you see the tumor is seen causing extensive infiltration. I hope I can show this. Yes, and also narrowing of the vascular structures. Now, the features which favor mass-forming chronic pancreatitis include duct penetrating sign, collateral duct dilatation, and a pancreatic duct to parenchyma ratio less than 0.34, and also presence of pseudocysts. I'm going to talk about these signs a little in detail later on. This is another example of a patient with a mass-forming chronic pancreatitis. These masses are hypointense on T1 weighted images, iso to hyperintense on T2 weighted images, and can show decreased and delayed enhancement due to presence of fibrosis. Again, MRCP is often helpful for diagnosis of mass-forming chronic pancreatitis. The signs you see are ductal irregularity, duct penetrating sign, and branching duct dilatation. So this is what I was referring to as branch duct dilatation and duct penetrating sign. So if you see in the example here, this is a dilated pancreatic duct where you also see dilatation of the side branches of the pancreatic duct, and you see that at the site of narrowing where there is a mass, you see that you are able to follow the pancreatic duct, which is not cut off. So that is a sign of mass forming chronic pancreatitis. You can also sometimes on T2 weighted MR images see intraluminal filling defects, which are either debris or stones, which can be seen on CT. This is another example of the duct penetrating sign. Duct penetrating sign refers to a smoothly tapering duct which is coursing through a mass. It has a very high specificity and accuracy for inflammatory mass versus pancreatic cancer, which causes duct cutoffs. So in the image on the left, you can see a dilated duct which are able to follow through the inflammatory mass, therefore making a diagnosis of mass forming chronic pancreatitis. Similar patient you see on the MRCP image where you can see the duct coursing through the inflammatory mass. This is an example of a patient who had chronic pancreatitis. This is a mass we saw in the region of the head of the pancreas, did not have vascular involvement. Often, despite some imaging features which allow you to make a specific diagnosis of mass-forming pancreatitis, we end up biopsying them for confirmation. These are the MRCP images in the same patient, where you can see that the duct is quite irregular. There is narrowing of the duct in the region of the mass. This mass was biopsied, and this turned out to benign pancreatic tissue with stromal changes and chronic inflammation. Of course, you don't stop there, because EOS biopsies can be negative. We often do short interval or 6-monthly follow-up in these patients to make sure that we don't identify cancer. And why is that important? Now, if you look at the relationship between chronic pancreatitis and PDAC, there are these two meta-analyses I want to share, which showed that chronic pancreatitis is associated with an increased risk of pancreatic ductal adenocarcinoma, anywhere ranging from 16 to 22-fold increase. So, though there is a strong link between chronic pancreatitis and pancreatic cancer, less than 5% of patients with chronic pancreatitis develop pancreatic cancer. Therefore, there are no active consensus guidelines to direct screening or surveillance of patients with chronic pancreatitis for detection of pancreatic cancer. So if you look at the estimated cumulative risk after 15 to 20 years of chronic alcoholic pancreatitis, it's around 4%. The mechanism here is ongoing inflammation leads to genetic alterations, which leads to development of cancer. Now, there can be overlapping imaging features, as I showed in my examples, because of stromal fibrosis, which can make a mass-forming pancreatitis look like a ductal adenocarcinoma. Some of the features which help you identify a tumor is development of a soft tissue mass, tumor vessel involvement, and peripheral displacement of previously seen calcifications called vanishing calcifications. As I mentioned, it's important to do short-term follow-up with pancreatic protocol CT or MRI in those suspicious cases, and EUS and FNA is often needed in those patients with high clinical suspicion. So this is an example from our cohort, where you can see this is a patient who had chronic pancreatitis, was followed, used to keep getting recurrent acute pancreatitis. You can see at 0 months you see the atrophic pancreas, but at 36 months, 3 years later, there is development of a hypodense mass in the uncinate process. This was biopsied and turned out to be ductal adenocarcinoma. Another example of a patient with recurrent chronic pancreatitis, you see there's a pseudocyst, or you call it a walled-off necrosis in the region of the body of the pancreas. Now have a close look at the region of the celiac axis and the splenoportal confluence. That's this region. So this is the initial imaging. Then you have a 6-month follow-up imaging and 12-month follow-up imaging. You see that there is a walled-off necrosis. There's atrophy of the tail of the pancreas. Now, 2 years later, you see now that there's a development of a soft tissue mass in the region of the celiac axis, which then went on to grow and cause narrowing of the vessels around the splenoportal confluence and the superior mesenteric artery. So this was a patient with chronic pancreatitis who developed PDAC on follow-up. Another important thing to remember, there's association between pancreatitis and PDAC. Patients who sometimes PDAC can present as acute pancreatitis, particularly in patients who present with acute distal pancreatitis. You always need to suspect PDAC when patients have no other cause for pancreatitis, but they develop pancreatitis in the body and tail of the pancreas. This is an example, clinical example, where you can see a patient had chronic acute pancreatitis affecting mostly the body and the tail, and had persistent symptoms, and the MRI was performed, which led to identification of a hypodense lesion here in the region of the body of the pancreas, which was causing obstruction and distal pancreatitis. This turned out to be pancreatic ductal adenocarcinoma. So again, remember, patients with chronic pancreatic cancer can also present with acute pancreatitis. Okay, with that, now let's move on quickly into the other condition which can often mimic pancreatic cancer, is autoimmune pancreatitis. I won't go into detail about autoimmune pancreatitis, but suffice to say that this is a systemic disease involving the pancreas. Often it results from periductal infiltration of IgG4 positive cells. There are diagnostic criteria which have been laid down for diagnosis of autoimmune pancreatitis, which includes a combination of histology, radiologic features, rising serum IgG4 levels, which are very important in the diagnosis of autoimmune pancreatitis, and also patients with autoimmune pancreatitis demonstrate a remarkable response to steroids, which can be used as a diagnostic criteria. So there are type 1 and type 2 autoimmune pancreatitis. I won't go into details here, but suffice to say that type 1 autoimmune pancreatitis, the involvement of the pancreas is part of a systemic disease, while in type 2 autoimmune pancreatitis, it predominantly involves the pancreas. If you look at the imaging manifestations, autoimmune pancreatitis can either have a diffuse form or a focal form. If you look at the diffuse form, autoimmune pancreatitis often manifests as diffuse enlargement of the pancreas with loss of lobulation, which gives us a sausage-like appearance. And you also see a hypo-enhancing capsular rim around the pancreatic body and tail, which is characteristic of autoimmune pancreatitis. Now, diffuse autoimmune pancreatitis is less likely to be confused with the pancreatic cancer, but what often can be confused with pancreatic cancer is focal form of autoimmune pancreatitis, where you can either have a unifocal lesion or you can have multifocal lesions. And these lesions often demonstrate features of any inflammatory mass, hypointense on T1 weighted images, hyperintense on T2 weighted images, and they can demonstrate delayed enhancement. Now, one of the features of autoimmune pancreatitis is involvement of extrapancreatic structures. So you can have involvement of the biliary system, we can have involvement of the kidneys, and also other structures like you can have retroperitoneal fibrosis, lymphadenopathy, and salivary gland involvement. So this is an example of a patient with autoimmune pancreatitis. You can see the typical involvement of the pancreas, where you see a sausage-like thickening of the pancreas with pericapsular rim halo around the pancreatic tail, but you also see the stricture in the distal end of the bile duct. So this patient had involvement of the distal biliary system. Another manifestation, that is involvement of the kidneys. You can see multiple wedge-shaped cortical-based hypodense areas in bilateral kidneys in a patient with autoimmune pancreatitis presenting with interstitial nephritis. Okay, now let's move on to the last category of lesions which can be confused with pancreatic cancer, that's paraduodenal pancreatitis. Now, paraduodenal pancreatitis, also known as groove pancreatitis or cystic duodenal dystrophy, it's a focal form of pancreatitis which is centered at the pancreatico-duodenal groove. Inflammation and fibrosis can give to a pseudotumor appearance, and it can often extend into the pancreatic head to mimic cancer. Now, there are three distinct types of paraduodenal pancreatitis described: solid tumoral type, with minimal cystic changes, cyst-forming subtype, and ill-defined type presenting with inflammation. So this is the type 1 paraduodenal pancreatitis. Here you can see there is a mass-like appearance in the pancreatico-duodenal groove involving the pancreatic head. So this was a solid tumoral type of paraduodenal pancreatitis. This type is often difficult to differentiate from pancreatic cancer growing into the pancreatico-duodenal groove. It's the same patient where you can see on the MRCP, this patient actually underwent resection of the tumor, and this turned out to be a solid mass, paraduodenal pancreatitis and not cancer. Type 2 paraduodenal pancreatitis has a cystic appearance, so you can see the large cystic mass in the region of the pancreatico-duodenal groove, and that's the typical manifestation of paraduodenal pancreatitis. This is less likely to be confused with pancreatic cancer. Again, another example of cyst-forming paraduodenal pancreatitis, where you see T2 weighted images demonstrating cystic changes. This is on the MRCP, where you can see the cyst-like appearance in the region of the pancreatico-duodenal groove. The third type, which I mentioned, is the ill-defined type, which is typically appears as inflammation in the pancreatico-duodenal groove and does not have mass-like appearance. So this is often manifests as acute pancreatitis. Okay, so I went over the imaging manifestations of the three types of inflammatory masses which can be confused with pancreatic cancer. Now let's try to see what are the differentiating features. I want to focus on pancreatic cancer and mass-forming pancreatitis. Now, some of the features which allow you to differentiate between these two entities are the duct penetrating sign, collateral duct dilatation, which are present in mass-forming pancreatitis, absent in pancreatic cancer, abrupt duct cutoff, double duct sign, marked duct dilatation. Involvement of the vessels is more common with pancreatic cancer and less common with mass-forming pancreatitis. So these are all the different imaging features. I talked about all of these, just going over a little more, so marked duct dilatation, where the duct is more dilated than atrophy of the pancreas, is more common with pancreatic cancer, less likely with mass-forming pancreatitis. You can see abrupt duct cutoff, the mass causing obstruction of the pancreatic duct. Duct penetrating sign is a manifestation of mass forming pancreatitis. Vessel encasement, involvement of the superior mesenteric and superior mesenteric artery and veins is again a manifestation of pancreatic cancer, not so much with mass forming pancreatitis. But sometimes those can be difficult to differentiate. Again, as I mentioned, double duct sign is a manifestation of pancreatic cancer. Mass forming pancreatitis presents as duct penetrating sign or collateral duct dilatation. Dual energy CT has been found to be useful, where the iodine concentration of chronic mass forming pancreatitis has been found to be higher in patients than in patients with pancreatic ductal adenocarcinoma. This is an interesting case. Patient presented with a mass, no prior imaging, had pancreatic ductal dilatation in the tail. We had CT, MRI, biopsy twice, was non-diagnostic. Surgeon went ahead and did a distal pancreatectomy, and any clue what this turned out to be? This turned out to be a benign inflammatory mass. So despite all the imaging features, sometimes the diagnosis can be challenging. Okay, autoimmune pancreatitis versus pancreatic cancer. We already spoke about the different features. This is just a snapshot of how you can differentiate autoimmune pancreatitis from pancreatic cancer. Autoimmune pancreatitis has typical imaging features of capsule-like rim, diffuser focal involvement, and duct penetrating sign. PET-CT has been looked at to differentiate between the two entities, and pancreatic lesions, or AIP, have lower SUV max than pancreatic cancer, and diffuse type of involvement of FDG uptake and extrapancreatic FDG site are more likely with AIP than pancreatic cancer. Okay, I think I'll be done quick. The time is up. We already spoke about paraduodenal pancreatitis. These are two patients. We have a mass in the region of the pancreatic or duodenal groove. Guess what the diagnosis was in both these patients? One patient presented with loss of weight and appetite, the other patient with abdominal pain. The first one was type 2 paraduodenal pancreatitis, and the second case was a cystic PDAC. So sometimes it can be difficult to differentiate. What about other clinical markers? CA99 is a good biomarker to differentiate the two entities, not so much CEA levels. Okay, that's it. So what we do at MGH is we have a multidisciplinary pancreatitis center, which allows us to discuss these cases on a weekly basis to do a multidisciplinary approach. So that's what we find helpful in discussing difficult cases. So that's to conclude. Differentiating can be difficult. There are certain imaging features which allow you to differentiate between the two, all the different entities. Serum biomarkers can be helpful, but you often need to do an EUSN biopsy to confirm diagnosis. Sorry, I rushed a little bit in the end, but I want to acknowledge my mentor and Kumar for sharing some of the slides, and thank you for your kind attention.
Thank you, Avinash sir. You broke down a very complex topic. It will help us very much in our daily reporting. We request the delegates and the chairpersons to save their questions after the end of all three discussions. Next, I would like to call upon our next eminent speaker, Dr. Michelle Mendiretta-Lala, for her talk on current controversies in HCC, the pearls and pitfalls in LIRADS. Dr. Michelle is the Director of Abdominal MRI, Co-Director of Interventional Oncology, Abdominal and Cross-Section Interventional Oncology in University of Michigan. Over to you, Dr. Michelle.
Hi, okay, thank you. I'm going to talk to you about LIRAD's diagnosis and treatment response, pitfalls and updates. If any of you came to the workshop yesterday, some of the content is a little bit similar, but we'll expand on it. So for the sake of time, let's start with diagnosis. So we know that there's an increasing incidence of liver cancer worldwide. It's the 5th most common tumor. And early and accurate diagnosis, prognosis, and personalized treatment selection and response monitoring after treatment is very essential in order to deal with this rise in HCC that we're seeing. We know that HCC has a wide biologic heterogeneity and behavior. What do I mean? There's a heterogeneous histology. We know there's at least 6 histologic subtypes of HCC. And heterogeneity affects the biologic behavior. So when a patient gets diagnosed, is it aggressive? Is it indolent? How does it behave in the patient? And the biologic behavior also affects staging, which ultimately impacts prognosis and treatment. So it's kind of a spectrum that we see. Unfortunately, or fortunately, HCC diagnosis and treatment management is usually imaging-based without the need for pathologic confirmation. We usually don't biopsy these tumors. However, these diagnostic and management algorithms currently provide this one-size-fits-all recommendation, and that's not really what we're seeing in real life. It doesn't take into account all of the prognostic data. So as radiologists, we must understand imaging biomarkers associated with aggressive or different biologic behaviors of our tumors that we're seeing on CT and MRI to help guide management in patients with HCC. Again, HCC tumor biology is associated with many factors. We have histopathologic cell surface markers, blood biochemical markers, the different histopathologic features, and even an immunologic imbalance in the tumor microenvironment. So the HCC pathology results in characteristic imaging features. We know that HCC develops on a spectrum of hepatocarcinogenesis. So we start with a regenerative nodule and kind of move down this spectrum to a dysplastic nodule and eventually into HCC. So the changes that are occurring on the cellular level give us these characteristic imaging features that we'll talk about. And based on these imaging features, we can provide a category and patients are managed and treated. So we know that these tumors have arterial phase hyperenhancement because of the recruitment of arteries. So they give us hyperenhancement on arterial phase. On our portal venous and delayed phase imaging, we get washout because there's a lack of portal tracts. So there's decreased contrast within the lesion during portal venous phase. Remember, 25% usually of the liver is supplied by hepatic artery and 75% by portal vein. But in these cases, these tumors have way more arterial supply than portal venous supply. And then there's a connective fibrous tissue which surrounds the lesion, and that demonstrates delayed enhancement, giving us this enhancing capsule appearance. Based on these imaging features, we have these categories, LR1 through LR5, plus LRM and TIV. LIRADS, the diagnostic algorithm, provides us this validated system for imaging-based diagnosis of HCC without the need for biopsy. In fact, there's many studies that look at the probability of malignancy based on the category, and when you look at LR5, you can see that there is a 97% chance that it's an overall malignant tumor. 94% of that is HCC. Therefore, AASLD and many other international societies no longer require biopsy when you treat HCC. So this is why LIRADS is very important, the diagnostic algorithm, because it provides this standardization, which is now being adopted worldwide. So it's, even though it was started in US, it's worldwide adoption. I think it's in 270 languages as well now, the algorithm. So not only does LIRADS give you a category, it also tells you how to manage patients. So I think the key features here are LR4, LRM, and TIV. Those, if you have that category, you want a biopsy in order to decide what your management is. But if you have LR5, you don't need to biopsy those lesions. And I know I've said that many times. So let's look at this patient. This patient has an LR4 lesion. What we see here is a patient with non-rim arterial phase hyperenhancement, measuring greater than 2 centimeters, but there are no features of washout, capsule, or threshold growth, so it's an LR4 observation. This was a biopsy-confirmed HCC. So here's an instance where we decided to biopsy the tumor. How about this patient? This patient has a lesion that demonstrates rim enhancement on arterial phase and portal venous phase, intense restricted diffusion. So this was an LRM observation. Biopsy revealed that this was moderately differentiated HCC. So here it was important to biopsy this LRM to differentiate cholangiocarcinoma from HCC. So we also know, because I also showed you in the first few slides, is we have a wide pathologic variety of HCCs. So HCC tumors can be divided into two molecular classes, a proliferative and a non-proliferative, and that really does affect outcomes in these patients. So for example, in this patient who has this large single lesion in the right lobe of the liver, this was biopsied and came back with an AXIN1 mutation. This is associated with a proliferative HCC. Management was TACE in this patient, and 18 months later, there was massive progression and the patient passed away. On the other hand, this large lesion, it's even larger than that first lesion I showed you, was biopsied, and it came back with the CTNNB1 mutation, which is a marker for a non-proliferative HCC. This patient was also treated with TACE, and you can see at 4.4 years later, there's no recurrence, and patient is doing very well. So approximately 25% of HCCs have potentially actionable mutations, whether it is HER2, microsatellite instability, looking at the tumor mutational burden, and these tumors will actually respond to immunotherapy and different forms of therapy. Unfortunately, we still rarely biopsy liver observations in high-risk patients. So, part of my talk is kind of LIRAD's pitfalls. I think this is a very big pitfall, but it's still, we still haven't changed guidelines that we should biopsy these tumors. So we'll switch a little bit over. All of this will connect in a few minutes now to treatment. So I told you that we have our diagnostic algorithm, we categorize a lesion, what do we do with our LR5, LRM, TIV category? Once we have a category, then we have to move on to treatment. So LIRADS also has a treatment response algorithm. We know that treatment for HCC is usually minimally invasive, local, regional, or liver-directed treatment. We treat patients for curative, palliative intent, bridging, and downstaging for transplant eligibility. Management is based upon our imaging. So if you present these cases at tumor board, we really know that when we stage these patients, we're treating them based on the imaging findings. So it's really important as radiologists to be very accurate in terms of how much tumor, size of tumor, location of tumor, et cetera, because our clinicians and patient management is really dependent upon our reports in order to manage them. The problem, however, is that not all LR5 HCCs behave the same. So while we know that the positive predictive value is near 100% for LR5 to be HCC, here you have two patients. The first patient and the second patient both have lesions in the caudate lobe, very similar in size, both in cirrhotic patients. The first patient had no recurrence 5 years after liver transplant, and the second patient had early post-liver transplant recurrence. They both were treated similarly. When you look carefully at the imaging, you can see that the second patient, especially where the red arrow is, has some imaging features which would suggest poor prognostic features, such as no capsule when there's washout, ill-defined margins of washout, kind of infiltrative washout, and a lot of surrounding perfusional changes. Now, our major diagnostic imaging features in the LIRADS algorithm does not capture the biologic heterogeneity of HCC. And that was kind of my purpose of this case. So while we are using this algorithm, while it is validated, as radiologists, it's still important for us to look at the image, look at the tumor, look at other features, because we could suggest these in our reports. Even if we gave this an LR5 category, you can say LR5, however, there are features suspicious for aggressive biology, such as subtle infiltrative washout or whatever those features are. So it's important for us to recognize those. Similarly, just like not all LR5s are the same, not all HCCs are the same. So we know we have LRM HCC and we have LR5 HCC. So in this first patient who has an LRM lesion, this was biopsy proven HCC, patient died within 3 months of diagnosis. The second case is an LR5 HCC, and the patient had a transplant and survived 5 years post-transplant. So again, we do know that there's a difference in HCC if it's LRM or LR5. LRMs tend to be more aggressive. So that one-size-fits-all model is a pitfall of the LIRADS algorithm. This study recently came out of UCLA by Steve Raman, and it shows that the histopathologic grade of HCC correlates to liver-directed therapy, specifically microwave ablation outcomes. So the blue line in both graphs is well-differentiated HCC that was treated with microwave ablation, and you can see overall survival and progression-free survival is improved when you have well-differentiated HCC. But that still puts us back to we don't biopsy all these lesions, how do we know? So there are certain prognostic imaging biomarkers which indicate microvascular invasion. The size, so very large size, very hypermetabolic on FDG, if there's an invasive growth pattern, so incomplete capsule, like I showed you in that one case, very intense restricted diffusion, macrovascular invasion, bile duct invasion, those are signs of poor prognosis. So that's something you could always add to your report. Again, a limitation of the LIRADS algorithm. Here's an example of a 54-year-old male with HCV cirrhosis, and you can see that there's an LR5 observation, this arterial enhancing mass with washout in capsule, restricted diffusion. However, if you notice, along the cranial margin of this tumor, you can see this somewhat more ill-defined arterial phase enhancement, and you can see 2 additional lesions that are LR4. So now you've got multifocality, even though they're LR4. This patient was presented at tumor board, and decision was made to do microwave ablation. So 2 of those areas that LR5 and 1 of the LR4s were treated. You can see 1 month post-ablation. Looks pretty good, right? However, I don't know if my mouse is showing. The one thing that you see on this is that there's this kind of tubular area of washout. This was still called non-viable because there was no arterial enhancement. 3 months later, the patient came in, and what you're seeing now is ill-defined enhancement, tubular washout, restricted diffusion, macrovascular invasion with this tubular area of enhancement and washout extending into the portal vein, marked restricted diffusion, so this was viable. So this is an example of early recurrence that perhaps if, as a radiologist, we had recognized some of those aggressive features, we could have suggested a different treatment modality. So that begs the question, should we be changing management in patients with high-risk HCC? The IMbrave 050 trial was recently published, and it was a phase 3 study looking at adding atezo-bev to patients with high-risk HCC treated with resection, TACE, or ablation versus active surveillance. And originally, the RFS benefit was seen. However, once the trial finished, it showed that really there was no benefit. And so AASLD practice guidelines, which were recently updated and released, say that we should not treat patients with atezo-bev or neoadjuvant systemic therapy, even if they have high-risk features on imaging. Okay, I don't have a lot of time, but we're going to really quickly get into our treatment response algorithm now and just talk about some of the pitfalls and updates with that. So currently, there are many therapies for HCC, as we know, surgery, intraarterial radiation, thermal ablation, and even systemic therapies and immunotherapies. The original LIRADS treatment response algorithm was released in 2017, and the problem with the old, it's not even that old, but the first algorithm was that there was one algorithm for all forms of treatment, no matter what type of treatment you had. So all of these, no matter how you treated the patient, we interpreted it the same way. However, we found out over time, as evidence emerged, as people published papers, that really our imaging findings after treatment varies based on the type of treatment that the patient had, and so we really need to have separate algorithms. So the new algorithm, therefore, was updated and now has 2 separate algorithms, one for non-radiation and one for radiation-based local regional therapy. So let me skip through this and go to here. So the key concept for non-radiation treatment response assessment, so this is thermal ablation and intra-arterial embolic therapies, so bland embolization, TACE, DEB-TACE, is that tumor response should be immediate. You should see no enhancement immediately after treatment. Any enhancement at any time is considered viable, and those patients should be managed accordingly. When you look at the algorithm, then you've got a non-viable category, meaning no enhancement. Viable, it's definitively enhancing. And then an equivocal category where we're not really sure if this enhancement is related to viable tumor or perfusional changes post-treatment, and we'll just wash those patients. So let's look at some examples of expected post-treatment changes. You'll often get coagulation necrosis from the thermal ablation. So that is this high T1 pre-contrast signal, and if you do it with CT, you would see hyperdense appearance. You would get no enhancement, which you can confirm with subtraction images. Sometimes you get a smooth perilesional rim of enhancement, and often you get perfusional changes. Here's another case of an LR5 observation. Here you can see the ablation zone size. You always want to have the ablation zone larger than your tumor to treat any microscopic disease. We see no enhancement in this tumor, or in this of the tumor, and gradual decrease in size. So this is kind of your expected post-thermal ablation and intra-arterial embolic therapy appearance. Here I'm showing you this case again where you can see arterial enhancement with washout. So this, I like this case because of two reasons. Let me show you this mouse. Okay, well, if you see where the red arrow is, well, if you look on your arterial phase, you see two areas. Just under the capsule, you see an area of arterial enhancement, and then you see the tubular area at the 3 o'clock position. When you look on your portal venous phase, you see the area from about the 8 to 11 o'clock position is iso-enhancing. So that's a suggestion that this is perfusional and not viable tumor. Okay, some people had this question for me at the workshop yesterday as well. How do you know it's not progression? Even though we're not using our portal venous phase imaging to decide whether there's viable tumor, it can help you still in terms of interpreting the imaging. The area at 3 o'clock is washing out, so that is suggestion that that's viable tumor. So I like this case because you kind of get an example of both of that. Here's two examples of viable tumor. In the first one, post-microwave ablation, you have persistent nodular enhancement. And the second one, after TACE, you can see persistent enhancement in the tumor. So again, that's compatible with viable disease. Real quick to touch on ancillary features, one of the updates to the new algorithm is that we added ancillary features to help us categorize lesions. So originally it was only, is it enhancing or is it not enhancing? But what we found from a lot of data that was published is that if there is restricted diffusion or T2 signal in your area of enhancement, that can help upgrade you from equivocal to viable. So let's look at an example here. We have an LR5 observation treated with TACE. On our 1 month post-TACE at the yellow arrow, you can see that there's a crescentic area of enhancement, a little bit of restricted diffusion. So with the original version 2017, when you're only allowed to use enhancement to categorize viable tumor, you may say, well, this patient had TACE and it might be perfusional changes, so I'm going to call this equivocal. Well, if we were able to use version 2024, you could use that restricted diffusion to upgrade it immediately to viable. In this case, since this patient was presented or had this MRI before 2024, you can now see at 3 months there's progression, and so this at this point is definitively viable. So this is one of the updates to the algorithm. Now that was specifically non-radiation forms of therapy. So in about 45 seconds, I have to talk to you about radiation-based therapy. Hopefully I'll get 2 more minutes. Okay, so radiation therapy is Y90 and SBRT. So in order to understand imaging findings after radiation, I think it's really critical to understand the pathophysiology of radiation-induced cell death. So there's 2 pathways after a patient gets Y90 or SBRT. You have direct damage, where you get double and single-stranded DNA break, leading to immediate cell death. These tumors on post-treatment imaging are going to be non-enhancing, easy, non-viable category. However, there's this other indirect damage pathway that you see after radiation therapy, where cellular damage is not immediate. You get free radical and reactive oxygen species formation in the tumor microenvironment, which leads to cellular senescence. That means the cell is still alive, the cell is still metabolically active, however, cell division is arrested. So that's why, and then eventually that cell will die off. So we think persistent enhancement after radiation is likely related to the fact that the cells are metabolically active, but they cannot replicate, and eventually the cells will die, which explains differences in post-treatment imaging after radiation compared to other forms of conventional therapy. So that is kind of the key concept with radiation. You may see persistent enhancement after you treat with Y90 or SBRT. You don't want to, as a radiologist, call that viable because the patient can get repeat treatment unnecessarily. And we know that these patients with cirrhosis have more morbidity from repeat treatments than the cancer itself. So let's just go real quick to this algorithm. So the difference with this algorithm versus the first algorithm I showed you now is the non-progressing terminology. So instead of using equivocal, we changed it to non-progressing. That means that the tumor is still enhancing. However, that enhancement is stable or decreased in size when compared to pre-treatment. And the reason we use the term non-progressing is because our clinicians, our oncologists, hepatologists, surgeons think, okay, it's non-progressing, great. We just continue management with 3-month imaging in these patients, and it reduces unnecessary retreatments. So quick example, I'm going to give you a couple quick examples. In this patient, LR5 lesion treated with Y90, pretty easy, there's no enhancement. You see a lot of perfusional changes in the parenchyma. This is non-viable. Here's another tear patient, LR5. Post-treatment, you see the smooth peripheral rim of enhancement with no central enhancement. A lot of perfusional changes after radiation having to do with radiation fibrosis. And again, this is non-viable. Here is an example of SBRT. So you can see an LR5 pre-treatment, and at 3 and 12 months, you still have enhancement of the tumor. In fact, you would think you didn't even treat this tumor because it's enhancing so much. So we know it was treated because you can see the radiation changes in the surrounding parenchyma. Because this is SBRT or radiation treated, this would be considered non-progressing and really nothing you have to do. If you think about that concept, at 12 months, if this was viable tumor, the tumor should be getting larger, right? Because the cells are going to replicate. The fact that it's not getting larger is a sign that really we don't need to do anything. We can just watch and wait with this case. Let me see if there's any. Let's look at this case real quick. So this is a patient who had Y90 of an LR5 lesion. Every time point you see decreasing enhancement, and so it's non-progressing at every time point. If I told you that this was TACE, however, every time point would be viable. So I really want a take-home message with this updated algorithm is that it's critical to know what treatment the patient had. I can throw up any picture here, and if I tell you what treatment, you'll have a different category. You really need to understand the pathophysiology of cell death. Here's an example real quick of viable. So it's non-viable, new enhancement, so it becomes viable now. So now the patient should be retreated. And I guess we can stop there. Hit a few more slides. So one thing is systemic therapy, do not use LIRADs. You want to use RESIST or M-RESIST with systemic. So in conclusion, HCC diagnosis and management is almost exclusively imaging-based without the need for pathologic confirmation. There are imaging features that, as radiologists, we should identify, which could be predictive of a more aggressive biologic subtype of HCC, which could result in early post-treatment recurrence and worse overall survival. It's important for us to communicate that at tumor board. And as radiologists, we play a critical role in identifying these features. LIRAD's treatment response algorithm is a framework to describe treatment response for individual lesions. The updated algorithm provides updates to treatment response assessment considering different imaging findings after different types of local regional therapy. And overall take-home point is liver cancer diagnosis and management is a multidisciplinary, it requires multidisciplinary collaboration for management. This is our treatment response working group. We are the ones kind of work together to put together this new 2024 algorithm. And thank you. Sorry, that was long.
Thank you, ma'am, for shedding light on the evolving LIRADS categories and various imaging features. Our next topic is bile duct wall thickening by Dr. Avinash again.
Thank you. Here I am. Yes, there you go. So I'm going to talk about bile duct wall thickening, a conundrum. It seems like I've got the difficult topics of conundrums, so the mass forming versus now bile duct wall thickening. So these are my disclosures. I want to acknowledge the contribution of two of my colleagues at MGH, Mark Anderson and Anushanai Bangle, who've been really very generously provided some of their slides to me. So what I plan to do here in the next 20 minutes is review the differential diagnosis for bile duct wall thickening, discuss the imaging manifestations of malignant and benign causes of bile duct wall thickening, and try to discuss an algorithmic approach to bile duct wall thickening. So this is how the normal biliary system looks like. Normally the biliary bile duct wall is imperceptible. Even after contrast administration, you typically do not identify any wall. So if you are able to identify a measurable wall for a bile duct, either intra or extrahepatic, that means there is some degree of wall thickening going on. So this is how typically the normal bile duct looks. So when you think of bile duct wall thickening, it can be either intrahepatic or extrahepatic. It could be either isolated focal thickening or multifocal thickening. There could be a mass or there may not be a mass. You always look for associated features which include biliary narrowing, biliary ductal enhancement, and upstream ductal dilatation. And all these features are helpful in narrowing down the differential diagnosis. One important thing to do is to differentiate between benign and malignant cause of biliary ductal wall thickening, especially when you have a focal area of narrowing. So let's look at the differential features between benign and malignant biliary strictures. On the left side, you see a benign stricture which has circumferential duct wall enhancement. Often benign strictures can be multiple. They have smooth margins, and one typical diagnostic feature of benign strictures is a gradual transition to normal caliber that's tapering, and you could have upstream biliary ductal dilatation. However, it's mild compared to malignant strictures. Malignant strictures often cause irregular luminal narrowing. As you can see in the image, it causes asymmetric ductal narrowing. It can be solitary, and because they don't have tapering margins like the benign strictures, they can have shouldering with abrupt transition in caliber. And also the degree of duct dilatation is greater with malignant strictures compared to benign strictures. Now, there are various different types of differential diagnosis or causes for a benign or malignant involvement of the bile ducts. These include primary sclerosing cholangitis as benign causes, bacterial cholangitis, chronic pancreatitis can cause biliary ductal wall thickening, IgG4 related cholangitis, ischemic cholangitis, and other types of cholangiopathies. Malignant causes for bile duct wall thickening, the most common one is the cholangiocarcinoma. You can also have extension from pancreatic cancer or gallbladder cancer causing bile duct wall thickening, and of course metastasis to the bile duct can be encountered. So let's go over some of these different conditions which cause bile duct wall thickening and see how you can differentiate between benign and malignant causes. So I want to start with cholangiocarcinoma. This is a primary malignant tumor of the bile duct epithelium, has a poor prognosis, a 5-year survival less than 20%. The most common histological variant is adenocarcinoma. Commonly affects patients in the 6th or 7th decade. There are different risk factors which increase the occurrence of cholangiocarcinoma. If you look at the different types, there are 2 classifications for the types of cholangiocarcinoma. The anatomic classification, which defines cholangiocarcinoma as intrahepatic, perihilar, or distal cholangiocarcinoma. Perihilar tumors are located at the confluence of the common hepatic duct, are more commonly encountered, accounting for 50 to 60%, followed by distal cholangiocarcinoma, which involves the common bile duct. The morphological classification, that is the one which appears on imaging, includes the mass forming type, the periductal infiltrating type, the intraductal growing type, which occurs as an intraductal polypoidal mass, and the combined type of cholangiocarcinoma. So these are the typical imaging features of the 3 types of cholangiocarcinoma: mass forming, where you have an intrahepatic mass. This fits into the LRM category if you apply LIRADS. Periductal infiltrating are those which appear as malignant strictures causing narrowing of which have enhancement of the duct wall and cause narrowing of the bile ducts with upstream duct dilatation, and the intraductal one, which is a rarer variant of cholangiocarcinoma, which grows as an intraluminal polypoidal mass. Now, because this is bile duct wall thickening, I'm going to focus on periductal infiltrating cholangiocarcinoma, which can be a site of bile duct wall thickening. Now, this is most commonly encountered at the hilum, that's at the confluence of the bile ducts. Distal common bile duct involvement can occur in 20% of cases. As I mentioned, the typical imaging features include bile duct wall thickening, which is irregular. There is asymmetric narrowing. There is also upstream ductal dilatation. And because these have fibrous stroma, just like cholangiocarcinoma, pathology, they show early enhancement with persistent enhancement in the delayed phase. Now, if you look at the bismuth correlate classification for hilar tumors, there are 4 different types described. Type 1 involves a common hepatic duct below the confluence. Type 2 extends into the confluence. Type 3 extends, whether it's A or B, extends into the right or the left hepatic duct. And type 4 is multicentric, involving the confluence and both the right and left hepatic ducts. Let's look at some examples. This is a patient who has looks like type 1 periductal infiltrating cholangio, which is involving the common hepatic duct, just stopping short of the confluence of the ducts. This is another example of a patient where you see this is a type 3, where, or you could call it type 4, because you have involvement of the confluence of the ducts and extending into the both in the right and left hepatic ducts. This is an example of a patient with the distal CBD involvement. If you look at the image on the left, you see that there is here where you see there is a stricture causing enhancement and narrowing of the bile duct. But what helps you diagnose here is you can see on the MRCP images there's abrupt cutoff, and you can see the shouldered margin, which allows you to make a diagnosis that it's a malignant stricture. Okay, so this is an interesting patient. I'm going to show you some different cases we saw which appeared as malignant strictures but were not cholangiocarcinoma. This was a mass where you can see there's actually a mass in the region of the neck of the gallbladder extending into the common hepatic duct region. So this was a bile duct stricture from recurrent gallbladder adenocarcinoma. Another patient where we saw a small smooth stricture in the region of the common hepatic duct. This was biopsied. Turns out this patient had a prior history of colon cancer. This was a bile duct stricture, malignant metastasis from colon cancer. Another patient with colon cancer, metastasis to the bile duct appearing as a malignant stricture. This was another interesting case where you can see there was diffuse thickening of the common hepatic duct, both right and left hepatic ducts. Even the cystic duct was thickened here. Sorry, here's the mouse which shows the thickening of the cystic duct and diffuse thickening of the common hepatic duct and the biliary system. This was biopsied. This was actually ovarian cancer metastasis to both the extrahepatic bile ducts and the cystic duct. Another example of metastasis to the bile duct, in this case it was gastric adenocarcinoma with metastasis to the bile duct, which was non-contiguous with the primary tumor in the stomach. This was a case of hepatobiliary lymphoma, which caused bile duct wall thickening, and you also see confluent masses, which is very FDG avid. Another example of a hilar lymphoma which caused bile duct wall thickening. Of course, here it appears like a smoothly enhancing mass, so you're going to biopsy this. So this is difficult from the run-of-the-mill bile duct wall thickening cases. So again, hilar lymphoma presenting as diffuse bile duct wall thickening. This patient again presented with bile duct wall thickening. This patient had metastatic TCC. This patient had bladder cancer, which had metastasized to the bile duct. So I've showed you cases of cholangiocarcinoma which present with malignant stricture. We can also have metastasis, though rare, which can present just like cholangiocarcinoma. Now let's look at some of the benign causes of bile duct wall thickening. Now benign causes of bile duct wall thickening could be cholangitis, commonly cholangitis, which could be either infective or inflammatory involvement of the biliary tree. Common infectious causes are acute bacterial, recurrent pyogenic, parasitic, or HIV. Autoimmune causes include primary sclerosing cholangitis or IgG4 related, and then there are other rare variants of bile duct wall thickening, either eosinophilic, ischemic, chemotherapy-induced cholangitis, or xanthogranulomatous cholangitis. This is a patient, typical history, 49-year-old patient presenting with jaundice, right upper quadrant pain and fever. What you see on the images here is there's multifocal areas of bile duct wall thickening and enhancement. There are also patchy areas of T2 hyperintensity and abnormal enhancement on the portal venous face. This was acute bacterial cholangitis. Acute bacterial cholangitis occurs due to bacterial contamination of an obstructed biliary system, often caused by gram-negative bacteria. Clinically, the patients present with the typical, what's described in the literature is the Charcot's triad, where they present with right upper quadrant pain, fever, and jaundice. There are several different etiologies for development of acute bacterial cholangitis. Commonly occurs in patients with prior biliary surgeries or biliary strictures, and also with choledochal lithiasis. This is another example here. You can see a patient with acute cholangitis with presenting with multiple abscesses in the dome of the liver. This is a 63-year-old Asian man presenting effort from overseas for consultation. What we saw on the CT and MR images is that there is a segmental biliary ductal dilatation involving the left hepatic lobe. Also on T2-weighted MR images, you can see there are filling defects, hypointense filling defects in the dilated biliary tree, which looked like hepatoliths, and this was a case of recurrent pyogenic cholangitis. Recurrent pyogenic cholangitis occurs due to recurrent episodes of bacterial cholangitis, often seen in patients of Asian descent. It can be due to parasitic in origin. Recurrent inflammation leads to bile duct fibrosis, stasis, and inflammatory strictures then lead to stasis, which then causes hepatoliths within the intrahepatic bile ducts. These patients can progress to have biliary cirrhosis or portal hypertension, and cholangiocarcinoma can be encountered in 5 to 18% of patients. Management of these patients often requires a multidisciplinary approach. This is another example of a sort of a very florid case of recurrent pyogenic cholangitis, multifocal strictures throughout the bile ducts. You also see that there is hepatoliths which are filling the dilated bile ducts in the liver. This was a patient with transplant who had a very capacious rule limb, and this patient got multiple episodes of cholangitis and ended up getting recurrent pyogenic cholangitis. So where we again see diffuse stricturing, irregularity, narrowing of the bile duct involving predominantly the intrahepatic ducts. This is, we saw a few cases during the time when we had a lot of patients with COVID who presented with abnormal LFTs. This is a patient with COVID where we saw new development of multiple focal intrahepatic strictures and narrowing. And on the contrast enhanced images, you see the areas of arterial hyperenhancement. This was COVID-19 cholangiopathy. I don't know, we've not figured out what the cause for this was, probably related to microvascular ischemia or immune-related damage. And these patients with COVID cholangiopathy can present with features which just look just like primary sclerosing cholangitis. Often they end up getting liver transplantation due to recurrent biliary strictures. Another example of a patient with COVID cholangiopathy, here on CT, there you see that there's dilated bile ducts. There was also significant enhancement in the peribiliary region, and MRCP demonstrated multifocal stricturing of the intrahepatic bile ducts. Third example of a patient with abnormal LFTs, COVID. You can see multifocal stricturing, again another case of COVID cholangiopathy. Okay, this was an interesting case, an infective case, a patient with breast cancer who presented with abdominal pain, distension, night sweats, and weight loss. We saw diffuse biliary wall thickening both intra and extrahepatically. This was biopsied, and this turned out to be tuberculous cholangitis. This is an example of HIV cholangiopathy in a patient with known history of, we actually had very low CD4 count, and you can see there's diffuse involvement of the intrahepatic bile ducts with wall thickening and diffuse enhancement. Now, these are three different examples of patients with appearance which are typical for primary sclerosing cholangitis. Now, patients with primary sclerosing cholangitis, as you can see in the pictures here, manifest with multifocal stricturing involving the intrahepatic or the extrahepatic bile ducts with intervening areas of dilatation. Now, primary sclerosing cholangitis is a chronic progressive inflammatory disease considered to be autoimmune. It has a strong association with inflammatory bowel disease in nearly 70% of cases, often affects patients in the 3rd to 4th decade. There's a risk of cholangiocarcinoma, so patients with primary sclerosing cholangitis undergo repeated surveillance imaging every 6 to 12 months to identify foci of enhancement or dominant stricture. Imaging is key to the diagnosis of primary sclerosing cholangitis. Just again, typical examples of primary sclerosing cholangitis with multifocal stricturing involving the intrahepatic bile ducts. And when you administer contrast, you can see that the liver demonstrates heterogeneous enhancement, bile duct wall demonstrates thickening, including areas where there is no narrowing. Diffuse involvement, progressive involvement can lead to a prune tree appearance where the bile ducts may not be well visualized on MRCP images. Patients can go on to develop fibrosis and cirrhosis, and typically they have a box-like appearance, as you can see on the coronal images. Patient with primary sclerosing cholangitis who developed cirrhosis, portal hypertension. They can also have confluent fibrosis developing, as you can see on the image on the left side. One important thing to note is in patients with primary sclerosing cholangitis, they can develop cholangiocarcinoma. So there is a concept of dominant stricture when you have a CBD stricture less than 1.5 millimeter in diameter or affecting the right or left hepatic ducts. Important to identify dominant strictures because they could be both benign or malignant. One thing which helps you identify malignant strictures in patients with primary sclerosing cholangitis is the thickness of the wall. Anything more than 4 millimeters should raise suspicion for superimposed cholangiocarcinoma. The example you're seeing here is a patient who had primary sclerosing cholangitis, had a dominant stricture in the common hepatic duct. And these are images from the same patient who underwent, on the right-hand side, the patient underwent spyglass ERCP, and you can see that there is a mass in the region of the dominant stricture. On the left-hand side, you can see the normal appearance of the CBD. This is a patient, I had showed this earlier in my earlier talk, where you see that the pancreas is enlarged, is sausage-shaped, has a capsular rim, and you also see a stricture in the common bile duct. So this was a case of IgG4-related sclerosing cholangitis. Now, IgG4-related sclerosing cholangitis is immune-mediated. These patients often present with markedly elevated IgG4 levels. Similar to primary sclerosing cholangitis, they can present with multifocal strictures, but one way to distinguish IgG4 related stricture from PSC is that in patients with IgG4 related sclerosing cholangitis, the strictures tend to be longer and they show more thick circumferential rind of enhancement compared to those patients with primary sclerosing cholangitis. Again, these patients often respond very well to corticosteroids. The same patient, which I showed earlier, responded very well to steroid treatment, and you can see these are post-treatment images where the pancreas has nearly resolved inflammation and also the bile duct stricture has now normalized. Again, another example, this is a typical case where you can see a diffuse long segment narrowing of the bile duct with bile duct wall enhancement, another case of IgG4-related sclerosing cholangitis. Another example of a patient with IgG4-related sclerosing cholangitis, both with pancreatic renal manifestations and biliary involvement, had very high elevated IgG4 levels. I'm going to quickly go over the next few different types of cholangiopathies. Ischemic cholangitis typically occurs in patients after transplantation. This can be non-anastomotic or anastomotic biliary stricture. Non-anastomotic biliary strictures typically are multifocal, can be perihilar, and usually seen in the intrahepatic location, while anastomotic strictures are short strictures at the biliary anastomosis, and they can demonstrate peribiliary enhancement. Again, here the history is important to know for the development of ischemic cholangitis in patients who have had transplantation. Okay, so this is a patient who had metastatic lung cancer on nivolumab. These are the pre-treatment images. We can see the bile duct looks normal. After the patient was put on treatment, you see this patient developed diffuse narrowing of the intrahepatic biliary ducts, enhancement. So this was a case of immune-related cholangiopathy. Again, here the history is helpful. I'm going to quickly go over this. This was a case of Langerhans cell histiocytosis cholangitis. Again, this was diagnosed on pathology. Cystic fibrosis patients can have cholangiopathy. We have a clinic where patients with cystic fibrosis are seen, and we do see cases with cystic fibrosis presenting with biliary duct wall thickening and upstream duct dilatation. I'm just going to wait for that. And then, okay, cystic fibrosis cholangiopathy, these patients can then progress to steatosis, fibrosis, and cirrhosis. Portal cholangiopathy is an important differential diagnosis for biliary stricture. Here, portal vein thrombosis leads to development of periportal collaterals, which can lead to narrowing of the bile ducts and upstream duct dilatation. Okay, with that, now I'm going to go to the different. So we talked about different types of bile duct wall thickening. This is just a summary of the different benign causes of bile duct wall thickening and some of the important salient features which help you differentiate. From, if you think of a clinical perspective, CA99 has limited positive predictive value and really not helpful in differentiating. ERCP-based breast cytology is specific but lacks sensitivity. Often patients end up getting US-guided FNA for diagnosis of type of biliary ductal wall thickening. PET is controversial, that's why I am not included in the slides. Just a minute more and I'll be done. Okay, so this is an algorithmic approach to bile duct wall thickening. So when you see bile duct wall thickening, you see whether it's isolated or multifocal. If it's isolated and focal, look for features of malignancy. If you have features of malignancy, assess for cholangiocarcinoma or metastasis. If it's multifocal thickening, or if there is no features of malignancy, you check demographics and clinical history, whether patient has history of IBD, IgG4 levels, recurrent episodes of cholangitis, or it could be ischemic, helps you identify the type of cholangiopathy. Again, in patients with recurrent pyogenic cholangitis and PSC, you need to look for features suggesting malignancy. So that's it. So bile duct wall thickening arises from a variety of different benign and malignant conditions. Imaging can help differentiate causes. However, clinical history and demographics are crucial for accurate interpretation. Using an algorithmic approach can improve diagnostic accuracy, and early detection is important, especially for patients with cholangiocarcinoma. Thank you for your kind attention.
Thank you, sir, for making a complex diagnostic challenge feel far more approachable. Now we can have a 10 minutes discussion regarding the last 3 topics. Over to the chairpersons.
One of the delegates has asked a question. If a lesion shows arterial hyperenhancement with washout in delayed 3-minute images instead of portovenous phase, do we call it LR5? And at what phase is washout actually expected to be called LR5?
No, you are the expert now, so you should.
I didn't hear the question one more time,
Oh,
sorry.
yeah, the question is there, displayed there.
Lesion shows washout on the delayed phase. So yes, you can call it as washout, because washout is not only defined on the portal venous phase, it can be used on the delayed phase as well. Yeah.
Yeah, in fact, we use it, I use delayed, sometimes because there's so many dynamic, I put the arterial and the delayed, I don't even look at the portal venous, so.
Yeah, actually there was a study which looked at washout on portal venous phase and delayed phase and found that when you use a combination of portal venous phase and delayed phase, you actually increase the sensitivity and specificity for determining washout.
Congrats both of you for fantastic presentations. One question from myself, Dr. Avinash, about the indeterminate pancreatic masses. So what is the role of perfusion CT, perfusion protocol CT scan? Does it have any role at all in these masses which are difficult to diagnose? Or is it obsolete?
No, in fact, it's so interesting. When I was a research fellow, when I first started at Mass General, we used to do perfusion CT for pancreatic cancer. But I think we did 4 cases and that was it. We didn't do many more. So I hope that answers your question. So yes, I don't think perfusion CT is helpful. Plus, if you're doing perfusion CT, of course, it involves a lot of radiation. Now, you could do low radiation perfusion CT now with the newer scanners, but yeah, we have really not found it useful.
Avinash, what is the role for diffusion or PET CT or biopsy in that inflammatory Mars versus carcinomas?
PET CT, as I talked, in patients with AIP, we often end up sometimes getting PET CT. But I think ultimately it boils down to getting a biopsy, a good EUS-guided biopsy to confirm diagnosis. There are difficult cases, and I was talking about the multidisciplinary pancreatitis clinic we have, where we see these sort of cases every week. They just need close follow-up. There was actually recently, a month back, we had a patient who had a mass in the uncinate process, had 3 EUS-guided biopsy, and it all came negative. But the surgeon was not convinced. I thought it was malignancy. So surgeon actually had to open up the patient, take a biopsy from the uncinate process, and turned out to be cancer. So sometimes it's difficult. Despite all your efforts, despite PET CT, sometimes there are cases where you cannot make a diagnosis.
Okay. Dr. Lala, a question for you. So you very well described the futures where, the high-risk behavior of the, liver lesions yourself. So in case you diagnose high-risk behavior characteristics on CT scan, do the surgeons biopsy if the patient was otherwise for liver transplant to look for unfavorable biological markers? What does it mean? Do they biopsy?
We still don't biopsy, I would say. I don't know, do you guys biopsy if there's aggressive imaging features? I think if it's unusual features, we'll biopsy. When I see something aggressive, what I do is at tumor board, I just say, okay, this is LR5, but it appears like it's a more aggressive LR5. So if we're gonna do Y90, if you're gonna do radiation, you're gonna do microwave ablation, whatever treatment you do, you wanna make sure you treat a bigger zone of the tumor. Or, something that's less than 3 centimeters that on imaging, it looks like it's less than 3 centimeters, we would do microwave ablation. I would say maybe we should do Y90 or SBRT for this lesion instead, because I think it's probably infiltrative and more aggressive. You can get wider margins.
No, what it translates is those patients may not be suitable for a liver transplant if you can show that they got poor biology. So does biopsy make sense in such patients with such characteristics?
I think so, yes. I mean, I think that's going to be a system-related change, right? It has to be your whole, your health, whatever your multidisciplinary team is, you have to change the culture, but I think it would help, yes, because those patients naturally have a higher risk of recurrence post-transplant when they're immunosuppressed. If you've got a more aggressive form or proliferative form of HCC, those are the ones that are going to have early post-transplant progression. So I do think so, yes.
Because University of Toronto, I think, does liver biopsy for all such patients.
They do a lot more. And I would say the other thing, it depends on your pathologist. So sometimes the pathologist will just say HCC and that's it. So you need to make sure, on top of biopsying, that your pathology team is aware that they have to do, more intensive identification of cell surface markers and other histopathologic variants, and even genetic variants to be able to identify these more aggressive forms of HCC.
Absolutely.
I just got a simple question for you. It's just a fantastic talk, and I really enjoy the slides. It's all really captivating as such. Primarily from the TB and HIV, it just goes to the old school thought saying that it can present as anything and everything. So I just got one question about screening. What are your thoughts on abbreviated MRI? Because that seems to be the latest one which is going down for screening and surveillance in HCC. Because universally, the practice has been sort of 6-monthly ultrasound and AFP, but the abbreviated MRI, just capturing the series in 10 minutes, it seems to increase the sensitivity and specificity. Obviously, the resources is a constraint, but given that the fact that most of the HCC which we diagnose is at a later stage, where the treatment options is probably it's BCLC C or D, do you think that this is going to be the future?
Yeah, so for diagnostic purposes, I do think abbreviated MRI has a lot of utility. There are at least 5 or 6 papers with a high N, right? Many patients where they've looked at, they're all retrospective, of course, but they've taken the full series and then the, abbreviated series, and there's no diagnostic difference. Very little. It's not statistically significant. I think with strains on our resources, with the cost of imaging, with the number of patients we have to image, routine imaging, patients are getting more frequent imaging. I do think that there's a role for abbreviated MRI. I can tell you at University of Michigan, our wait time for MRIs right now is almost 60 plus days, 60 to 90 days. That's how backed up we are, and we have 18 scanners across the system. So actually in October of 2025, we have this initiative to decrease wait times significantly to less than 25 days. And so what I'm doing for liver diagnostic imaging is trying to implement an abbreviated MRI protocol. The issue, at least in the US, I would say, is that you still bill the patient, or the cost is the same whether it's abbreviated or full. So then you get into this, there's some people who say ethically, is it right? I think that if you can get imaging in 20 days as opposed to 90 days, and your diagnostic sensitivity and specificity is essentially unchanged, then I think it's worth it. So I do think there's a role.
So there are many more questions from the delegates, but I will ask one or two. Mixed HCC cholangio findings, and what will you do in LIRADS? Mixed cholangio and
Yeah, mixed tends to be LRM, so usually biopsy those. Look at tumor marker, CA19-9 AFP. Of course, could always be sampling bias. If you biopsy something, comes back HCC, it could be mixed or vice versa. But I think those tend to be LRM variant. Do you not agree?
Oh, I totally, yeah. All LRMs at MGH, we biopsy those. Yeah.
So in IgG4 disease, will you screen thyroid and the salivary glands when you suspect biliary IgG4 disease, autoimmune?
So yes, so all these patients, we don't do specific imaging for the salivary glands or thyroids, but these patients are usually seen by rheumatologists or pancreatologists. So they do screen for everything for these patients, but I don't know if they do screening for the salivary and the thyroid glands routinely for all those patients.
Bile duct mucinous neoplasms can present as wall thickening, biliary tree. One question.
Biliary mucinous?
Mucinous biliary duct mucinous neoplasms.
Yes, IPMBs. I did not include IPMBs. The reason was that because these appear as masses, I took off the slides because I thought, I just wanted to focus on bile duct wall thickening rather than intraductal polypoidal masses. Yes, they can sometimes mimic bile duct masses.
Thank you, both of you.
Can I say one thing?
Yes.
For liver imaging, and someone asked me this question yesterday, and I had a slide, I forgot to put it in. For diagnostic evaluation, you can do CT, MR, or contrast-enhanced ultrasound. All of them are approved for diagnostic determination of a liver observation, and for treatment response as well, CT and MRI. All of the concepts I spoke about, even though I had a lot of MRIs, apply for CT as well, except of course ancillary features. And new in 2024, you can do contrast-enhanced ultrasound for treatment response evaluation as well. You can go on the ACR website and find the algorithms for all of the diagnostic and treatment response.
Thank you for both of you for wonderful sessions. Thank you.
I would like to thank Dr. Michelle and Dr. Avinash for their extensive talks. Thank you for bringing us such complex topics into simple thoughts. Thank you, ma'am. Thank you, sir. I would also like to thank all the chairpersons. Thank you, sirs.
We are happy to invite our Rising Star Award winner in the consultant paper category now. We invite Dr. Surya Prakash on stage to present his work on quantitative CT texture analysis in differentiating lung adenocarcinoma versus squamous cell carcinoma. And Dr. Surya Prakash on stage.
A very good evening, one and all. And I take this opportunity to thank the KMCH organizing team and SOI team for giving a platform like this to present our study. And coming to my topic, in the recent years, there is a growing trend in quantitative imaging biomarkers, particularly for the evaluation of tumors and response of the tumors to therapy. This has led to the development of several quantitative biomarkers from advanced imaging techniques. And CT texture analysis is just one of its kind in the field of radiomics. And hence, we decided to work on the topic quantitative CT texture analysis for differentiating lung adenocarcinoma and squamous cell carcinoma. Lung carcinoma is the deadliest cancer, as we all know. It is the most common cause of cancer-related mortality, and it is very important to differentiate adenocarcinoma and squamous cell carcinoma, because for proper institution of therapy, this differentiation is needed. Histopathology is invasive and often delayed, and we think CT texture analysis might serve as a non-invasive tool for this subtype differentiation. Tumors are heterogeneous at the structural, cellular, and genetic levels, and the traditional imaging techniques and biopsy may miss these findings due to limited samplings. This texture analysis provides an objective and quantitative assessment of this tumoral heterogeneity by analyzing the pixel intensity and spatial resolution. And you can see the two different grayscale image. You can see the two different grayscale image. Each contains the same number of gray and black dots, but their arrangement is different. It is with the texture analysis we can easily quantify the intensity and the distribution, which will help in detailed composition of the tumor. The primary aim of our study is to quantify and assess the diagnostic performance of the texture features in differentiating adenocarcinoma and squamous cell carcinoma. We retrospectively evaluated the CT data sets for 15 months from Jan 2024 to March 2025, and we included all HPE proven cases of adenocarcinoma and squamous cell carcinoma who underwent CECT at our institute. And we excluded these cases, and from the 15 months, we had 74 lung carcinoma cases, of which we had included 42 cases for our study, and the texture analysis was done using Mazda software, and the statistical analysis was done using the independent t-test. We selected the single large diameter of the tumor CT slice for the maximum heterogeneity, and freehand ROI was drawn. And this is a very important to do normalization, pre-processing normalization to nullify the acquisition technique, patient size and different machines used. Normalization must be done. And finally, we did the texture analysis using the software. Basically, texture analysis will be done by three methods: statistical method, model-based method, and transform-based method. Our software Mazda provided us the advantage of including the parameters from all the three methods, and we had finally left out with 31 methods for 31 feature coefficients for analysis. So that was classified into first order, second order, and higher order. First, I can simply explain this complex term by the cookie texture analysis. If you see a cookie, the first order features are nothing but what are the constituents present in the cookies, be it white choco chips or dark choco chips or sugar composition, just the quantity. The second order tells the spatial relationship, how the dark chips and white chips are arranged. The third order gives the finer and more detailed texture like the composition. And in first order feature, we evaluated 7 variables, and in the second order 12 variables, and in the higher order 12 variables. A total of 31 variables were evaluated, and this is the diagrammatic histogram feature for first order. And with this we can simply explain the second order features. Second order feature is gray level co-occurrence matrix. Co-occurrence matrix is nothing but the total number of pixel pairs, be it the intensity or color, that occur in our matrix. The second order feature is gray level run length matrix, which means the number of pixels with the same intensity is the run length matrix. And higher order autoregressive model can also be explained here. Here the pixel of interest will be compared with the neighboring pixel in all directions. Theta 1 means horizontal direction and theta 2 means vertical direction, and in diagonal directions also it will be assessed. So the superior technique is wave transformation, and in wave transformation the image is converted into a frequency domain, and the images is analyzed after it is divided into 4 sub-frequency bands. And this is the tool interface when you open the Mazda software, and you have to upload your maximum tumor diameter, and then a freehand ROI is drawn, and you have to do the normalization, and you have to select all the features for analysis, and the maps will be presented, and finally the wavelet transformation, and you can do the entire analysis using the Mazda software. In our study, 85% of the cancer patients were male, indicating that the lung cancer is most commonly seen in male. Coming to the texture parameter analysis of the 31 parameters, not the first order, not the second order, only the higher order features, that is autoregressive theta 1, which means the horizontal directional heterogeneity, and wavelet HH and wavelet HL entropy, which means the fine texture variations are statistically significant. In addition, we could find some significance in the second order co-occurrence matrix. Our study results were concurrent with the results that were previously done in European countries. These findings reinforce that radiomic texture analysis may serve as a non-invasive biomarker for the subtype differentiation. So all the imaging representations that were given here are for visual pattern recognition and nothing to do with what you can quantify. And all the CT texture quantifiable values will be generated by Mazda software and given. And the center image is the wavelet decomposition analysis, which was statistically significant. This is a case of adenocarcinoma from our study. And to conclude, this radiomics based higher order texture analysis features show a strong potential in non-squamous cell carcinoma subtyping. Incorporating these higher order features into radiology workflow metrics might enhance the histological predictions. And I would like to add, this study needs large multicentric study with increased sample size and for better statistical power and to reduce the bias. And we should move from 2D slices to 3D volumetric imaging for better depiction of the tumoral heterogeneity. These are my references. Thank you. I am deeply grateful to my professor, mentor, guru, Dr. Devi Meenal for giving me the courage and strength and guiding me all through my radiology career. Thank you all for your patient listening.
Thank you, Dr. Surya Prakash, for presenting the futuristic work with us. And now I call upon Dr. Pankaj Sharma and Dr. Amarnath sir to present the medal and the memento to Dr. Surya Prakash. Thank you all. With that, we move to the next session.
It is my privilege to invite our esteemed chairpersons, Dr. Nityanand, Senior ENT Surgeon Consultant KMCH, Dr. Geetika Sindhwani, Associate Professor VMMC and Safdarjung Hospital, Dr. Ekta Dameja, Additional Professor AIMS Delhi, to kindly take their places on stage and preside over the upcoming session. Their outstanding contribution to the field and extensive expertise will undoubtedly enrich the discussions ahead. Ladies and gentlemen, please join me in welcoming them. First up, to take us through the imaging and management principles of laryngeal cancer, I request Dr. Sandeep Bhutta to please take the stage. Dr. Sandeep Bhutta, Professor, Neuroradiologist, Director of Research and MRI Supervisor, Griffith University, School of Medicine and Menzies Health Institute, Queensland, Australia.
Thank you, moderators, and good afternoon. I'm nowhere an expert in the laryngeal cancer. I think you probably see more laryngeal cancer than what we see down under in Australia, but I'm just going to present my local experience as to what we manage and what we do in these sort of patients. So I have no relevant disclosures, and we're going to go through the talk in this format. So look at the incidence, especially what is the incidence of laryngeal cancer in India, the TNM staging, gonna show some illustrative cases, and what are the key findings, and then what is the paradigm by the surgeons these days of organ preservation versus surgery. Most of you would have probably watched this movie on, I think it's on Amazon Prime, I Want to Talk. And the beauty of this movie is that we as humans, we all love to talk, and I can probably talk for another half an hour or probably an hour, and this is the biggest challenge for a patient with a laryngeal cancer, because if they're gonna lose their voice, nobody's gonna be very happy. And this is the whole crux. It's one of those most difficult situations in head and neck cancer, especially larynx, the patient has to go through. So one of the Beatles rock band in 1970s. I wasn't even born at the time, but one of the famous singers, George Harrison, ended up having a neck lump, and he was diagnosed with laryngeal cancer at the age of 50. If you go back at the history, it is very interesting that today we're talking about all sorts of CT scanners. We wouldn't have ever had a CT scanner in our life if Beatles wasn't there. So Sir Godfrey Hounsfield wanted to create this CT scanner, and everyone thought he was absolutely maniac when he said that within 45 minutes we're going to create the brain image. Nobody wanted to fund that project. But Beatles was doing very well, and they had signed this $1 million contract with the EMI Music Company. So he went to the Beatles and they said, here's the money, go and show us what you got. And that's how a CT scanner was born. And we have come a long way now from a conventional CT to up to a photon counting CT. So the pathology there is not a concerning feature. It's almost always a squamous cell carcinoma, about 25% of the head and neck malignancies. The incidence is definitely higher in this part of the world compared to USA, UK, or down under. Smoking is a very important cause for laryngeal cancer, and if you look at our population, one of the things which government has done well is they have massively increased the price of cigarettes. A cigarette pack in Australia costs $40. There's no way any common man can afford cigarettes, and that's why cigarette smoking has dramatically reduced in Australia and New Zealand. If you look at the Indian scenario, it is one of the very common top 10 cancers in this geographical area. It is a sad state of affairs. If you look at the data, I was quite shocked. About 250,000 of our population still uses tobacco, and excess alcohol, spicy food. The 5-year survival in the Indian scenario is around 28%, which is very similar to the rest of the world, and it is pretty expensive to get laryngeal cancer treated here as well. When it comes to imaging of the laryngeal cancer, we need to understand the anatomy. Unfortunately, I don't have much time to go through all of that, but we need imaging modality with a higher spatial resolution. Most of the patients would have had a baseline CT. We look at them with thin slices and bone windows. For an MR, we tend to do them on a 64-channel head and neck coil. Sometimes we may use surface coils, try to go with the minimal possible thickness of 2.5, 3 millimeters, use optimal fat saturation, and as well as diffusion-weighted imaging. Another important thing is that this is really for the juniors, is that your radiographers or techs might give you the axial slices in whichever way they want it, but you should be visualizing them with the perfect angle so that you're parallel to the vocal cords rather than angled in some weird sort of angle, because once you're parallel with the cord, then you actually have a proper view of the larynx and you can place the tumor in the supraglottic, glottic, or infraglottic location. So it is very important to have that angle corrected. You may have to do your own MPRs for that reason. Both CT and MR are excellent in defining the extent of the tumor, especially in the paraglottic space. If you have a dual energy CT, and if you're going to offer a patient only one CT, you should be only using dual energy CT. Small lesions can be very well seen. We tend to do T1 and T2 lesions on our dual energy scanner. The CT findings of cartilage invasion, the specificity is anywhere between 40 to 80%, but even in the best possible hands, mineralization, ossification of the cartilage, we still sort of struggle in that area. The negative predictive value of MR, however, is 96%. So when there is a crux point where you want to differentiate, has the tumor crossed across to the other side of the thyroid cartilage, we will definitely use an MR for that. The patterns of spread, what we are interested is the tumor can go up and down. So once it is in the paraglottic space, it is in a highway, it can go up towards the supraglottic larynx, piriform sinus, tongue base, can go all the way down towards trachea. Anterior and posterior spread going towards anterior commissure, posterior commissure, or hypopharynx, and the submucosal spread only we can see it because it is complete endoscopically occult. We make a huge difference there. And then the extralaryngeal spread where the tumor goes beyond the larynx to involve the other structures. Now let's talk about the Broyles ligament. Like, we don't have much of an understanding, but our head and neck surgeons do. So Broyles ligament is this complex of anterior commissure and your vocal tendons. As they join together at the level of anterior commissure, it forms the Broyles tendon complex. And the beauty of this is that the inner or internal perichondrium of the thyroid cartilage here is thin. So whenever the tumor involves the anterior commissure, it is more likely to erode through the cartilage and get to T3 or T4 because it's a weak point where the cartilage is missing. Now, when it comes to CT and MR, we are excellent in defining the paraglottic space. Sorry, it's gone backwards for some reason. Okay, we're looking at the patterns of spread here. I've just drawn a graphic over here, just as we described the cord pathology, anterior 2/3 or posterior 1/3, and you can see the anterior and posterior paraglottic space. The anterior 2/3 lesions are easily accessible by laser and usually have a good prognosticating sign, whereas the more in the posterior paraglottic space are a little bit hard to treat and have a relatively poor prognosis. The pre-epiglottic space best seen in your sagittal plane or axial plane, and we know that the pre and paraglottic space can communicate with each other as well. For cartilage invasion, we look at the inner thyroid lamina, cricoid cartilage complex involvement, and is the tumor on the other side of the cartilage. Now, when it comes to TNM staging, T1 and T2 lesions, we are not particularly concerned as long as there is no nasty surprise or there are no lymph nodes, which they were not expecting. But the T3, T4 disease is something which we are really interested, because this is where we make a difference, and this is where they can be occult, and we want to put our best foot forward because you don't want to understage them or overstage them at all. Now, these are the areas where we make a huge difference as far as the management is concerned, where the anterior commissure is involved and has the tumor crossed over to the other side. Is there a submucosal spread? Only we see it. A head and neck surgeon is not going to see that on endoscopy. Is there a subglottic spread? Is there a transglottic spread? Cartilage invasion, extralaryngeal spread, tracheal ring involvement. Is the hypopharynx normal or involved, and is the esophagus involved? Now, here's an example of a small T1 lesion. You can see there's a good endoscopic correlation. You can see this sort of whitish looking thing on the true quad on the left side. And it is sometimes can be pretty tricky to identify, but if you have a correct angle, if you're looking at it, and if you're especially using a dual energy CT, you should have no problem in identifying this, and you can clearly see that on an endoscopy view as well. Now, this is a case here of a 40-year-old male, an opera singer, obviously wanted to preserve his voice. You can see this lesion sort of anterior 1/3 on the right quad, and I'm showing you an example of here an appearance of the cord looks kind of red. This is post-laser resection, and you can see a PET CT has been performed after the laser resection, and there is no avidity. So most of our patients with T1, T2 lesions get a laser resection. Now, here's an example of a 62-year-old male where there was a bulky anterior commissure. You can clearly see that there is involvement of the thyroid cartilage anteriorly. I love to look at the coronal plane. You can see the extension, the tumor going down much, much lower than what was clinically thought. You are at the level of the cricoid cartilage. You are seeing the C of the cricoid cartilage. The tumor is involving the trachea as well. This is the best example I usually love to show. This is a supraglottic tumor. We have no problem in identifying it because we see it everywhere. Where is the tumor going? Anteriorly, posteriorly, but this is the endoscopic view. And you can see that if you look at this tumor, you can see this sort of involved epiglottis. You see this whitish necrotic tumor, and you can see there is a limitation of even seeing the true quads. And this is a pretty friable tumor. Nobody's going to really show in the endoscope because you can potentially dislodge the tumor. So this is where there is a kind of limitation on endoscopy, whereas we don't really have that limitation on our CT and MR, and we can see the tumor very well. Now, this is an example of a submucosal spread, and you can see here that the tumor is on the other side of the mucosa, completely on the other side. You can see it is paraglottic. It can go anteriorly and hug your piriform sinus. In this case, it is even going down further down laterally on the left side, going up to the cricoid cartilage. So this is the submucosal spread in a 61-year-old. Now, here's another example of a 45-year-old male with hoarseness of voice, young patient. And what you can see here is a transglottic involvement. So, sorry, my mouse is not working, I think. So, okay, maybe I can show it this way. Yeah. So you can see here that the tumor is going all the way down left paraglottic area. In this case, the thyroid cartilage was only inner lamina, but patient ended up having total laryngectomy, and often very reassuring to see that it was histopathologically proven that the cartilage was involved. because of extensive involvement. Now, this is where, when it comes to T3 versus T4, we traditionally have used MR to identify that, because in a high quality MR, we often have no problem in identifying the disease on the other side of the thyroid cartilage. But what I wanted to mention here is that if you have access to a dual energy or a spectral CT, then you are definitely a step ahead. We love to look at these images on a 40 kAV mono-E maps. Once you're using the mono-E at 40, the iodine boost, the iodine signal is so strong that you would never miss that compared to a conventional CT. And I'll show an example in a minute. So assessing the tumor cartilage interface, the tumor bone interface is exquisite on a dual energy CT. And we have performed these studies in patients with renal failure with as low as 40 mils or 30 mils of contrast. So you can do a great CT at lower dose. This is something a few years ago we mentioned, we presented at the ASNR, that if you do an iodine density maps, the values, you can do a measurement always close to 2. So you can differentiate a normal mucosa from an abnormal enhancing mucosa by doing iodine values. And here's a perfect example of a patient with, you can see here, there is mass here on the right anterior cord. The left cord looks completely normal on endoscopy. But you can see here, if you do these maps, you clearly have enhancement, thickening of the anterior commissure, tumor crossing over onto the other side, also involving the anterior third of the left cord, and you can do the iodine measurements as well. This was not thought of on the endoscopy at all, so it was clinically not thought about. Now, this is something which a head and neck surgeon doesn't really expect us to see or do much about it. These are just small, tiny, whitish plaques. This is leukoplakia of the vocal cords. But if you really spend some time and do mono-E maps, you can see these tiny bumps on the vocal cord. And sort of days have arrived that we have started seeing leukoplakia on the vocal cords with the dual energy CT as well. Now, this is a textbook example of a T4 larynx. We have no problem identifying on PET. Maybe there is some enhancement on the other side, but I'm going to show you a comparison. On the left is your conventional CT, and on the right is your dual energy CT. And look at that iodine enhancement. You will have no problem in seeing that enhancement extending into the strap muscles of the larynx. You can also see that lymph node here much, much better. You can do further workstation assessment. And you can see here, you can create these sort of PET-like iodine maps. So color is always better. We as humans have a limitation of how many grayscales we can see, but we can see the color vision much, much better. And then you can further go and see, this is endoscopic correlation. You can do measurements and prove, in this case, the iodine values were close to 2 milligram. So it was definitely tumor. And then on this one here, you can see we were pretty happy to say that the tumor extends down, involves the thyroid cartilage. Not only that, it also involves the tracheal rings. This is how we conventionally assess them on an MR on diffusion and post-contrast fat-SAT, tumor enhancement on the other side of the thyroid cartilage, clearly a T4A disease. In this patient, there was also involvement of the piriform sinus. And this is something now I've tend to mention more and more in our reports. If you see enhancement in the trachea, ideally we should not be seeing that. We tend to mention the tracheal ring and try to mention for a surgeon as to up to first or second or how many tracheal rings are involved. In this case, we mentioned that, we were correct. Here is a histopathology specimen which proves that there was thyroid cartilage involvement, and surgeons ended up removing first 2 tracheal rings, and there was disease in the tracheal rings as well. Now, there are cases here where you cannot sort of work it out whether the tumor started on the laryngeal side or the hypopharyngeal side. We struggle, sometimes the surgeons might struggle as well, because it's just a complete mess and it's really difficult where the tumor started from which side. There are cases like that. Now, in this particular case, this is a 63-year-old with T4 larynx. In this case, you can see I showed you something similar in the workshop. If the tumor extends to the platysma, there is a bit of fat stranding. Sometimes might be an overcall, but we tend to call this possible skin involvement and may need a pectoralis flap. And in this case, we were happy to sort of say that there is possibly prevertebral invasion. Surgeons were happy they could move the larynx. It was not fixed, so they went ahead with the laryngectomy. In this case, we were really, really comfortable calling that this is a T4B disease because it's plastered to the prevertebral fascia. You see a lot of enhancement. Larynx was fixed. there was skin involvement, and this means it's a palliative approach for a patient as it cannot be moved. And this is an obvious fungation onto the skin surface. I love showing this case because this has been unusual. You have extremely necrotic nodes in the laryngeal cancer, something which you may or may not always seen, but always look at the sagittal plane. I want you to point here to this linear enhancement going further down, and this is hypopharyngeal involvement going down into the upper or cervical esophagus. So it can happen, and the patient may need a esophagectomy at the same time. Now, Delphian node, this is a little bit special just because it happens in this area or with thyroid cancer, so-called pre-laryngeal lymph node. You will have this sort of necrotic looking, bumpy looking thing in front of your thyroid cartilage, which is a Delphian node, which often drains. It's the anterior compartment. If it is present, you're better off mentioning that separately, because when you do a neck dissection, Delphian node is usually not addressed at that time because it's not correspond to level 2, 3, or 4. All right, so I'm going to spend a little bit on management part of it. I'm not a surgeon, neither am I a radiation oncologist, but it's just principles. At least at our place, I spend a lot of time with my radiation oncology colleagues planning the radiotherapy. Most of the smaller lesions are treated. You have an option, patients have an option whether they undergo radiotherapy or laser resection. The outcome is equally amazing. There are surgeons who perform partial laryngectomy, definitely not at our place, because the studies have shown that with partial laryngectomy, the outcomes are equally good, but the voice outcomes are not as great compared to radiation or laser therapy. Now, there has been more and more push towards organ preservation. So the goal is to not overtreat and have a perfect balance so that patient can also have a voice. When it comes to submucosal involvement, pre or paraglottic involvement, which we see quite well on CT, changes the management. A transglottic extension also means that more than likely patient is going to fail radiotherapy. Patients may opt for it, and sometimes they might still preserve the larynx. Then you might end up with osteoradionecrosis of the larynx, and patients will end up having a salvage laryngectomy at a later stage. At our centers, we do perform robotic laryngectomy pretty routinely, and I'm going to show you an example. Now, when it comes to T3 disease, it's often lob or laryngeal preservation treatment. If it's a T4A disease, total laryngectomy is often performed. If the tumor extends beyond the larynx, involves the postcricoid hypopharynx, then often a pharyngolaryngectomy is needed. Prevertebral fascial involvement, T4B disease, involvement of your neurovascular bundle more than 270 degrees can be a sign of a possible surgical difficulty. And I mentioned to you about salvage laryngectomy. Now, when the pharynx is involved, if the skin is involved, often they will rotate a pectoralis major flap to cover that skin defect. And when the pharynx is removed, then the neopharynx is usually reconstructed to create that pathway. And we know that most of the patients are nil by mouth, and before they start getting fluids, we'll often do a contrast swallow to show that there is no leak. Now, this is a graphic I've created. I would like to thank two of my surgeons who I work very closely with, John O'Neill and Sam Dothwhite. So the black graphic shows you that this is a laryngectomy. At least at our place, the hyoid is preserved because of difficulty in swallowing. The green line shows you what is a pharyngolaryngectomy. When the pharyngolaryngectomy is performed, at our place, we don't tend to use jejunum because it will cause stenosis. So often ALT is harvested from your thigh, it is rolled into a tube, and an ALT is used to reconstruct or create a neopharynx. Now, this is a case I couldn't help myself. Hopefully the video works. So this is a patient who already had radiotherapy in the past. There is a stump of tracheostomy, as you can see. This is using a Da Vinci robot for robotic laryngectomy, and you can see that at the moment you're getting an incision done through the epiglottis, so the larynx is getting mobilized. Just had to be patient, a little bit of cautery, and as we move forward, you can see most of the larynx has been now mobilized. Okay, there it is. Now you're holding the larynx. And this is insane, right? I mean, this is absolutely crazy. And you can see here now, robotic laryngectomy is performed and the larynx is delivered from your mouth. instead of an open laryngectomy. So this is absolutely cool. So I'd love to show this because it's pretty exciting. So I'm going to finish off in a couple of slides. This is something which we all go through in our mind when you're repeating a laryngeal case. This is not any rocket science, but this is something which I look at it, or I go through when I'm looking at a case of laryngeal cancer. Use what AJCC, or you should be using 8th or 9th. That's the most current one. Can you identify the disease on the laryngeal side or hypopharyngeal side? Often your surgeon would have told you that. Is the post-cricoid hypopharynx normal? Because that matters. How much of pre or paraglottic space is involved, what sites are involved. Are you happy with the cartilage, inner cortex, outer cortex? Is the invasion through and through? What's happening with the neurovascular bundle? And then what's happening with the prevertebral space? Is the esophagus okay? Is the skin being involved? Are the nodes unilateral or bilateral? And are there any distant metastases? Imaging pearls, as mentioned to you, early lesions at our place at least are treated with laser surgery or radiotherapy. Anterior commissure is very important. We make a huge difference. Look at it carefully. It should never be more than 2 or 3 millimeters. And when you're scrolling on your axial plane, there should be no soft tissue in your subglottis whatsoever. Any soft tissue in the subglottis is abnormal. That means there is a tumor. T3 versus T4, larynx preservation versus laryngectomy. Use the best MR, what you have, and thinnest possible slice to get those images. We often spend a lot of time doing the sagittal plane imaging if the prevertebral fascia is of interest. So in conclusion, I've quickly taken you through some principles of laryngeal cancer management. We play a huge role in tumor boards, and surgeons do rely on our findings, especially if the cartilage is involved or not. And more there is push towards laryngeal preservation, and the minimally invasive and robotic surgery are only going to push the boundaries even further. I would like to thank my team. I've learned a lot from my surgeons over time, and thank you very much.
Thank you, sir, for that excellent presentation. You've given us a glimpse into your invaluable methods of approaching laryngeal cancer, which will be of immense use to all of us. We are grateful for your time and effort. Now let's move on to the next session on dealing with another diagnostic conundrum, osteonecrosis versus recurrence of tumors in mandible by Dr. Diva Shah. Dr. Diva is a senior consultant at GIC Prime Diagnostic Center, Gujarat.
Very good afternoon to all of you. So at the outset, I would like to thank entire organizing team of SOIICON 2025, Dr. Venkatesh, Dr. Matthew sir, for giving me this wonderful opportunity. So let's begin in next 20 minutes. I'll be talking about imaging differentiation of osteonecrosis versus tumor recurrence in the mandible. So we all are aware that in oral cavity cancer, major treatment diagram is surgery followed by radiation in most of the cases. So objectives of my talk includes understand the post-radiotherapy changes in mandible, to differentiate ORN and recurrence by various imaging modality, highlight the key imaging features, pearls and pitfalls, how to differentiate, and certain reporting tips. So what is the definition of ORN? Necrosis of a mandible within the irradiated field with or without overlying fistula or persistent non-healing ulcer for more than 3 months when the radiation dose exceeds more than 60 gray. So this is ORN. The high risk after radiation in a radiated field following 6 months up to 12 months are the high risk, but we have seen ORN happens following 1 year also. Now, why the mandible? See, we have seen radiation therapy in multiple head and neck cancers which is being treated, but mandible is one of the most common site. Why it is so? Because it has a unique blood supply. Now, what is this unique blood supply means? Mandible has getting the blood from the periosteal vessels. These are the end arteries, while the teeth sockets that get a supplies from the inferior alveolar nerve artery. So whenever there is a resection, the surgery happens, they resect the periosteum, then they do marginal mandibulectomy. So overall there is a less and the very minimal supply. After that, the radiation happens that causes further necrosis. And that is why the mandible involvement is one of the most commonly involved bone in head and neck cancer to develop the osteoradionecrosis. Clinical presentations are quite variable. They may be persistent, localized or diffuse pain, Patient presents with the trismus or headache. There is exposed bone, soft tissue changes that occurs with or without ulceration, necrosis of the soft tissue of overlying affected bone. Patient may present it with the infection or purulent discharge, and sometimes there is a pathological fractures due to weakened and devascularized bone. So whenever patient comes to the surgeon, the most common investigation that they offered is the OPG, orthopentagram of the mandible. So here you can see really that there is a fractured bone with the sequestration formation on the right half of the mandible. Sometimes you can see the subtle changes that there is a osteolysis and some cortical destruction, and at that point of time it is really surgeons are interested with what's happening to the mandible, what's happening to the surrounding soft tissue structures. So imaging workflow for radiologists, which is very important. The MDCT is important to see the bony details, while MRI, of course, we know it is to know the extent of the soft tissue, what happening to the surrounding structures, the nodes and the nerve. PET-CT is not really recommended to differentiate when surgeons are looking for ORN changes, but definitely it has a role now in a locally advanced cancers who have been treated with the surgery followed by chemoradiation to rule out the recurrent disease. And PET-MR we are doing at our institution for overlapping cases. So to begin with, first let us see what are the stages of ORN. Here the surgeons are also they are also eager to know from us, if you are telling it is ORN, then what is the stage of the ORN? So following radiation therapy, there is a osteoclastic necrosis and apoptosis that happens. Following that, if there is any injury to the teeth or tooth extraction that happens, that leads to further changes in the bony mandible. That is why where it is important to understand that the dental injuries or dental extraction leads to bone consolidation, that is cancellation, bone resorption that initially happens. Followed by there is a cortical disruption that happens, which leads to the morphological changes in the mandible. After cortical destruction, you may see patient presented with either complaint of the trismus or pathological fracture. So here are some of the important early pattern which you need to understand along with the ORN changes. So here you can see that there is a lysis of the bone which is focal, but there is a linear continuous periosteal reaction that is seen. This is the type of the interrupted laminar variant of the periosteal reaction, while this is a solid type of periosteal reaction. And you have to see this kind of sequestration, separated bony fragments to locate and to tell to the surgeon, that is also very important. So this is a cortical and partially separated trabecular variant of the sequestration, while here this is an example of the trabecular sequestration, and on the left side you can see the mixed type of cortical and trabecular sequestration. Here are the examples of the advanced ORN features where you can really see destruction of the mandible, the sequestra formation, trabecular, and there is a peri and paramandibular air foci, gas formation you can see here. Now you have three sets of images here. So what do you think, which is abnormal? Of course we can see the middle and on the left it is a abnormal. So here there is a focal scoop out erosion which is you can see, while on the left side you can see the cortical irregularity with endosteal sclerosis and medullary air foci. Now, apart from the bony details, soft tissue differentiation is also important at the juncture to differentiate ORN versus soft tissue recurrence. So here you can see that wherever there is a focal soft tissue which is enhancing, it is more favoring towards the recurrence, while in ORN there is just a minimal edema or minimally enhancing muscles of the masticator space or subtle paramandibular soft tissue that you can see. So what are the key imaging signs for ORN and recurrence which we have seen in our previous slides? So whenever you see subtle cortical irregularity or sequestrant presentation, fragmented bone, there is no or minimal soft tissue or bulky muscles, while in recurrence there is a definite soft tissue you can see, and the erosion is more aggressive focal scoop out type erosion which you will see. So here this is an example of MRI operated case of a right buccal mucosa. It was stage 2 radiated, and you can really see that something happening on the right side of the mandible. The subtle intermediate more towards the hyper signal intensity area. The diffusion is not really showing the restriction. The ADC values were 1.1, and you can see these are the post contrast MR images that there is a subtle enhancement of this mandibular marrow which is hyper enhancing, and of course there is an enhancing streaky edema of the muscles of the masticator space as well. You can see this video, I don't know when, yeah, it's going on. So you can see we have fused the images of the PET and MR. Here you can see that the marrow which was showing enhancement, it is not showing uptake. There's a subtle mild uptake on the anterior and superior aspect of the cortex of the mandible, and there is a streaky muscle edema. So here are the imaging pulse on MR. The signal of that soft tissue was mildly hyperintense. There was no diffusion restriction. On PET, there is a mild focal uptake. And when we fused it, there is an area of the focal uptake, but rest of the marrow, which was looking like that is metastatic involvement, it is not showing. And on CT, so this kind of reformations are also very important in mandible. Whenever you are looking any changes, try and do oblique reformations. And here you can see typically a cortical sequestrum formation. Coming to the next case, a patient who got operated for the left lateral malignancy and radiation was given. Followed by that, he also developed the soft palate malignancy and then presented with continuous pain in the left anterior jaw and lower jaw. So this was a PET which was done on October 2023, which was given as there is a subtle uptake at the operated bedside. So this was given as osteoradionecrosis. Then patient has persistent pain, and following that again follow-up PET CT was done. It showed that the uptake was increased, and you can see some irregularity and lesion which looks like developed. And on January, following persistent symptom, and clinically they were finding, yes, there is some ulceration which was bleeding on touch, so that PET and MR was done in this patient. You can really see that there is a gradual increase in the FDG avidity of that lesion, plus you can see involvement of the central arch and left side of the mandible. The same patient, when you look at the MR, you can clearly differentiate the post-surgical fibrosis of the tongue. Here you can see the developing soft tissue which is involving the mandible as well. And if you see the restriction, you can see really the restriction at the level of the central arch and the left side of the mandible. So this is where you can really differentiate the PET and the MR features of where you can differentiate the recurrent soft tissue, and you can also differentiate the post-surgical changes. Coming to the next case, operated case of the left buccal mucosa, patient following radiation, patient has already developed ORN. Now following ORN, when patient was already on therapy, there was a persistent swelling and post-discharge was there. So surgeon has asked to do the MRI. So on the MRI, you can see this is a coronal T2 weighted, and you can see that there is not significant soft tissue, but the entire mandible got destructed, and you can see that there are some bony chips here, and that is showing the communication with the overlying skin. And these are the same MR axial and diffusion weighted images, which is not showing significant soft tissue, and there is no significant restriction on diffusion weighted images. Now here the CT part is important in this patient, because you can see multiple chips on MRI, which you can really well see on CT cuts. Now here what is important to give to the surgeon when patient is a known ORN, when you are ruling out the malignancy or perineural spread, and in this scenario it is important to give the 3D reconstruction. This is most important, to give a 3D reconstruction so that surgeon can really plan their management. So this is an advanced stage of ORN who is presented with secondary infection. So here the choice of the surgical treatment, they have to redo this flap, they have to remove the mandible. So these are the scenario where we help by giving the multiplanar reformation, and we have to give the 3D reconstruction. And this is the surgical specimen of the same patient. Patient got redo surgery, removal of the older flap, removal of the mandible. Coming to the next case, a known case of carcinoma of right GB sulcus post-operative, and then reoperated and recurrence, which was done in 2007, which was happened in 2017. Now there is an ulcerative lesion at the right angle of mouth. So you can see that there is at an operated bedside inhomogeneously enhancing soft tissue, which you can really see at the right side of the flap, which is involving the paramandibular muscles, and there is a significant heterogeneous enhancement. And this is the FDG PET of the same patient. You can see focally significantly increased radiotracer uptake. So this is nothing but this is a recurrence. So on MRI, the key imaging signs includes to differentiate ORN versus recurrence. That is, when the signal on T2 weighted, either it is heterogeneously hyperintense, when you see the typical peripheral enhancement, minimal soft tissue, and you may see or may not see restriction, but in most of the ORN, you do not see the restriction. While recurrent lesions will show a T2 intermediate signal intensity, there is an irregular solid mass, inhomogeneous enhancement, and diffusion restriction. Now, looking to this images of a patient who carcinoma of left buccal mucosa post-wide excision was done, post-radiated. When you look at this just bony reformation, you can see, yes, there is a bony restriction, there is a cortical irregularity. So this looks more as like this is a ORN changes. Now, when you see on your soft tissue window, you can see, yes, there is some irregular developing soft tissue along the mandibular area, which is involving the lip also, and clinically there were an irregular ulcer at the operated site. Now, if you move further, you can see there's a thickening which is seen at the posterolateral aspect of the maxillary sinus, and there's some soft tissue which is at the pterygopalatine fossa and pterygomaxillary fissure also. So this raises the suspicion of the recurrence with the perineural spread, and FDG has confirmed intense uptake and perineural spread along the maxillary division of the trigeminal nerve. This is another example of a patient with looking like ORN changes and has a persistent pus discharge from the submental region. So this is a FDG PET images, and this is the CT reformation, sagittal reformation. As we move forward, you can see here the fistulous communication from the oral cavity along with the mandible. You can really see the osteoradionecrosis, which is involving the lingual cortex of the mandible plus sequestrum formation. So this is how all combination of the modality help to differentiate ORN versus recurrent changes. So PET-CT has a phases where when you see a focal uptake, but you really do not see the soft tissue, it is favoring more towards the ORN changes. When you see typically enhancing soft tissue, here is an example at the operated bedside, so that is a recurrence. So again, there is a repetition of the same, but there are pitfalls on PET-CT because FDG gets accumulated at the inflammatory or infective site. So you really need to be very conscious of giving your differential. You need to see whether there is any nodal disease, perineural spread. So sensitivity and specificity of FDG PET has been found to be better than CT, of course, for detecting the tumor, but we have to keep in mind the pitfalls also. So as I said, multi-parametric imaging strategy is helpful in differentiating ORN versus recurrence, and you have to assess for progression over the time, evaluate the node, muscles, and the nerves. So this is the multi-parametric strategy, and PET-MR helps in some overlaps. So here, this was an interesting case of a operated left lateral border of the tongue. So this is the FDG PET, and this was given as, yes, there is a subtle uptake, there is a sequestration formation. So this was given as osteoradionecrosis, but the surgeons said that the ulcer is not looking good to us. So let's do further what we can do. So he has asked to do the MRI, and in this MR, you can see, yes, there is subtle soft tissue at the mandibular erosion site, which you can see really here, which is intermediate signal intensity. It is showing lower ADC values of 0.97, and it is showing heterogeneous, inhomogeneous enhancement. So this becomes NIRADS 3. So PET has given NIRADS category 2. This is 3 with the clinical information, and this is the fusion on PET and MR. Again, we have stick to the NIRADS 3. It got biopsy, and it turned out to be a recurrent squamous cell carcinoma, and patient got operated, and here you can see it was stage 1. So this is how combination of modality gives a proper and better confidence to us to categorize the lesion into NIRADS 2 to NIRADS 3. Coming to this is one of my favorite case which I have done before a year. That patient got operated for right lower alveolus and radiated in 2022. Now he presented with neck pain and persistent pain at the operated site. So when you look at this CT features, yes, there is a subtle cortical irregularity of the superior cortex of the mandible, and there is a focal uptake along at the operated side and medial to it along the ventrolateral aspect of the tongue. So looking to this, since clinically nothing was seen, so we have thought that this is a NIRADS category 2, that this is a early ORN changes, and this is just a physiological uptake. But since there was a persistent pain, we thought to do, let us do the MRI. So first we did the plain MRI, but then we found, yes, there's something going on along the alveolar nerve canal, and we did the contrast MR. Along with that, we have fused the data of the FDG PET, and this is the fused reformatting image of the PET MR coronal. You can see, yes, there is this uptake which is continuous along with the inferior alveolar nerve. If you compare the inferior alveolar nerve, which is thickened here as compared to, and there is a thickening along the foramen oval as well. So these are the PET MR images. There is a persistent thickening. This thickening, then we thought it is related to the lingual nerve. So basically there is a thickening of the lingual nerve, there is a thickening of inferior alveolar nerve, and it is extending up to the foramen oval. So this is nothing but it is a perineural spread. So this from Neeraj category 2 to it becomes Neeraj category 4 on PET and MR. So there are a couple of challenging mimics which we have to keep it in our mind whenever we are differentiating ORN versus tumor recurrence. So it can be osteomyelitis, it can be post-surgical infections, it can be necrotic tumor. So here is an example of patient of osteoradionecrosis. You can see a large you can see this large cavity formation and the dead bone sequestra formation on patient which was on biphosphonate therapy, which is one of the known complication of biphosphonate therapy. Again, this was a case which I remembered have done it before 2-3 years, that this was the lady who was operated for right lower GB sulcus tumor, and following that the radiation was done, but there is a soft tissue which you can see here along the interior aspect of the mandible. There were granulation tissues clinically. So this was done in February 2017, and patient was kept on a follow-up looking to that this can be a osteoradionecrotic changes. But in April 2017, you can see that there is an increase in size of this soft tissue, plus the mandibular erosion was also increased in the extent. So this I thought, like I have told surgeon that let us go for this biopsy, and biopsy showed that there are atypical cells, but nothing was found. Finally, since there is a persistent increase in soft tissue, increase in bone erosion, surgeon have done the surgery. It turned out to be a actinomycosis. So this is typically a case of infection which we also have to keep it in our mind, and which mimics as a recurrent tumors. I think I can skip this. A patient of a left buccal mucosa marginal mandibulectomy, it was T2N0, and there is multiple peripherally enhancing lesions along the operated side. You can see the FDG PET, and along with that there is a destruction of the mandible which you can see. So this was given as abscess with the fistula formation. They've done the aspiration. It turned out to be, yes, there are pus cells, but the wall also shows the squamous cell. So this is a metastatic necrotic inflammatory abscess mimicking recurrent lesion at the operated bedside. The last few slides, the radiologist reporting checklist, detailed clinical history, operative and radiation history is very important. You have to look for bone integrity. The cortical and medullary bone analysis is most important. Look for the air foci, look for the sequestrum formation, look for the marrow signal and enhancement if you are looking for the MRI. Look for the soft tissue component, FDG uptake pattern, whether it is diffuse or focal, it is intense or mild. Look for the nerve involvement very critically, and recommend the biopsy if discordant clinical and imaging findings. So to conclude my talk, ORN and recurrence may overlap. CECT is the choice of imaging investigation. CT plus MRI is problem solving in most of the cases. Sequestrum with or without periosteal reaction and no mass is more towards favoring the osteoradionecrotic changes. FDG PET is only indicated in a strong suspicion of a recurrent disease in loco-regionally advanced cancer, particularly to rule out the distant metastasis, and on FDG enhancing mass plus focal intense uptake leads more prompt towards the recurrence. Follow-up interval imaging is also useful in Neeraj category 2 and 3 type of lesion. And last but most important, never forget to ask the clinical details. And if you get a chance, take a clinical picture of your patient. This is most important in any head and neck evaluations. Recommend the biopsy, as I said, when in doubt or discordant clinical features. Please join us at ISHNR annual conference at Rishikesh on 10th and 11th, 12th October. And there's another symposium which we are conducting at Ahmedabad along with the Indian Society of Thyroid Surgeon, Imaging in Thyroid and Parathyroid Gland. The registrations are free for this thyroid and parathyroid symposium. And Rishikesh, of course, a holy city. So I would like to invite all of you for this one of the best of its conference. Thank you all.
Thank you, ma'am, for bringing clarity to a truly challenging imaging puzzle. Now I'd like to open up the floor for a brief discussion.
Very nice presentation, ma'am and sir. Actually, we don't have much questions from the audience, and only thing that I can highlight is the role of imaging in differentiation of osteonecrosis with the recurrence. It is very much dilemma for the surgeons, treating physicians. When we give the patient definite diagnosis of osteonecrosis, it is very much relief for the patient itself.
So fantastic presentation by both the speakers. So I'd want to ask one last question to Divasha. So it's basically not very easy to differentiate recurrence over osteonecrosis of early stages. Both of you will have a similar clinical pictures. I understand there is multimodality of the imaging will definitely help. So if at all there is a single modality which would help, which do you prefer? The second question is the same changes of osteonecrosis will replicate in chondronecrosis of the larynx, or it will differ, or if the modality of choice will differ based on the subside larynx versus oral cavity?
Yeah, so for both the questions, I would like to say for whenever the surgical and the surgeon wants to rule out ORN, when clinically it is looking more as osteoradionecrosis rather than the tumor recurrence, CT scan is the choice of the modality, first thing, to see the bony details. Even if we do MRI, we have to have a plain CT scan to see the bony details. That's the first thing. And early ORN, yes, it is difficult to pick up, but there are some ancillary signs which I have shown you when there is no soft tissue, but you can see really this kind of periosteal reaction which happens. Sometimes there are small foci of air foci which is seen in the vicinity of that subtle lysis which you see. So whenever the early ORN, you are going to see some kind of periosteal reactions. So that's very important to pick up, and that can be picked up always on CT. So that's the one thing.
Other is that it is not always one modality we as a radiologist can choose. Many times things are a mixture of things, and we are really confused only. So it is always a multimodality imaging that plays a role. Only sometimes we are confident enough to use a single modality to reach up to a diagnosis, but in many cases we also need multimodality imaging.
Practically in an Indian scenario, I know there are restrictions of the modalities because this surgeries and the treatment of the cancer is quite lengthy, quite expensive. So the best of a solution is to do CT, but the second best option is to do MRI with contrast and take a plain CT cuts. That's best thing to do, at least for the laryngeal, what you have asked to differentiate ORN versus, so that is suffice. Thank you.
That brings us to the end of discussion. We thank our chairpersons and our speaker for a wonderful session. Just as the right contrast brings out the details in an image, the right chairperson brings depth and focus to a session. We are now delighted to have Dr. L.R. Selvan, Senior Oncosurgeon KMCH, and Dr. Devash Shah, Senior Consultant GIC Prime Diagnostic Center, Gujarat, to preside over the next session. Please welcome them to the stage. Dr. Devash Shah, Senior Consultant, GIC Prime Diagnostic Center, Gujarat, we welcome you to the stage. First up, we have a talk on approach to lung nodules in patients with malignancy by Dr. Subha Digumarti. Dr. Sobha Degumarti, Clinic Investigator, Associate Professor of Radiology, Mass General Hospital, Boston.
Good evening again. Thanks for inviting me here. Today I'll be talking about approach to lung nodules in patients with malignancy. These are my disclosures, nothing relevant for this talk. The purpose of investigating nodules in lung in a patient with cancer is to, one, to decrease unnecessary workup and procedures, and at the same time identify nodules that are significant at the earliest go so we can reduce the delay. So this is the balancing act we have to perform. The lung nodules are classified as solid and subsolid. I don't have to define what a solid nodule is, whereas subsolid nodules come in two different flavors. They are ground glass nodules and part solid nodules. Per Fleischner guidelines definitions, a subsolid nodule is considered to be a ground glass nodule if the increased haziness or attenuation of the lung parenchyma does not obscure the underlying bronchi and pulmonary vasculature. Whereas a part solid nodule has both solid and a ground glass component, and in the area where there is a solid component, it does obscure the bronchial margins and also the pulmonary vasculature. But in theory, it is not always easy to separate a ground glass nodule from a part solid nodule. Even experienced radiologists can make mistakes, and in one study, there was a discrepancy of around 36%. And interestingly enough, if a same radiologist looks at a subsolid nodule, can call it as ground glass and part solid when there is a time difference between the interpretation. When you look at a lung nodule, incidental nodule, the rule is to measure it in 2 dimensions, make the average of the two to give the mean diameter. This is the standard for measurement of solid nodules. The same thing also applies for a ground glass nodule, where you measure the entire axis of the ground glass nodule in 2 planes and you take the mean. When there is a part solid nodules, we measure the entirety of the nodule. At the same time, we also separately measure the bi-axis measurements for the solid component, and we give them as 2 separate measurements. Say for example, somebody has a 2 centimeter ground glass nodule and also has a solid component of around 6 millimeters. We say a 2 centimeter part solid nodule with the solid component measuring 6 millimeters. This has bearing on the management, and also it implies some amount of histological characteristics of this particular nodule. For a patient with a known cancer or a tumor, when you're certain you're measuring the tumor, we have to take only one axis measurement, and this is the longest axis measurement when you're trying to define the TNM staging for the patient. This can be any of the planes. It can be transverse, coronal, or sagittal plane. But this should not be confused for measurements you make as part of tumor response for RECIST, where you always make the measurements in axial plane. The 2 important components for nodules is size and growth. The size is linked to risk of malignancy. The bigger the nodule, the more is the risk for malignancy. Nodules which are less than 4 millimeters have less than 1% risk of being cancers, whereas nodules that are 8 millimeters have around 10 to 20% risk of lung cancers. A nodule which is greater than 2 centimeters has almost a 65% risk of being malignant. So as the size increases, the probability of cancer increases, therefore your suspicion for malignancy also increases. The other important guiding principle is the doubling time. Malignant nodules tend to have a doubling time between 100 to 400 days usually. But if you want to shrink the range, we can also say anything which is more than 20 days is probably malignant. Anything which is less than 20 days is definitely not malignant. But having said that, most of the cancers tend to have a doubling time of over 100 days. Whereas infectious and inflammatory nodules have faster doubling time, usually less than 20 days. And there are also another spectrum, very indolent malignant tumors that have doubling times of over 400 days. We also want to be aware of the concept of temporary growth regression in patients who have malignancies. So this is an example of a mucormycosis. You can see a nodule in the periphery of the left upper lobe. If you see on the CT scan on the chest X-ray, the volume has quadrupled in volume in a matter of 5 days. This is definitely a very aggressive infection inflammatory process. This would be very atypical for a malignancy. On the other hand, a nodule in the lingula right next to the heart, which is growing very slowly over 5 years, suggests a more indolent process. This is typical for slow-growing neoplasms such as carcinoid. But having said that, there are also some histological variants of malignancies, even metastatic nodules, that can have very slow growth. The typical example would be metastasis from papillary thyroid carcinoma. In a lung cancer screening, we take advantage of the doubling time, because lung cancers usually have doubling time of less than 400 days. If we do annual screening, it gives them enough time for the nodule to increase in volume, and it is easy to make a diagnosis of an actionable nodule or a nodule which is high risk for malignancy. It is also important in a patient with any malignancy to go back and look at the old images to see if this nodule has predated the diagnosis of a cancer. In this particular example, the patient had a diagnosis of melanoma, which was deep. Therefore, there was a high risk for metastasis. When we looked at the scans, we did notice a lung nodule, but we went back and we noticed that this nodule was present 3 years before the initial diagnosis of melanoma, and this was behaving more like a lung cancer. So always be aware that lung cancers can exist. Lung cancers can be indolent. If you have the privilege of looking back, looking at the old scans, try to compare the nodule over time. The temporary growth regression is a rare phenomenon, but I do not want anybody to get fooled by a nodule which has shown transient decrease in size. This usually happens when there is an inflammatory component or when the tumor is occluding a small peripheral bronchus, which is causing some post-obstructive change. The temporary decrease in the ground glass component in this case was initially thought to be a benign process, but 2 years later, actually rather 4 years later, it turned out to be lung adenocarcinoma. The attenuation of the nodule is also important. Most of the nodules which have calcified, we tend to think that these are benign nodules, but I want you to be mindful. There are some patterns of calcifications that suggest non-benign pattern. The two classic examples would be stippled calcifications and the eccentric calcifications. The fat is also another interesting thing to think about. So this is a mass, or rather a nodule with an eccentric calcification. Now this type of calcification does not suggest a benign process. You have to take them seriously, because several cancers can form dystrophic calcifications. This was a case of large cell neuroendocrine cancer. The other one on the right side of you, it shows a irregular mass-like appearance with eccentric calcification. This was a necrobiotic nodule in a patient with rheumatoid arthritis. But when we are looking at this scan in a patient with known malignancy, we were more worried about it being a primary lung cancer. The fat attenuation is also interesting because it is not always easy to pick up fat in the background of air-containing lung because of partial volume averaging. But when you can see fat, you want to have a value of at least minus 60 HU to be confident that this is fat. We usually take a range of minus 30 to 60, but if you get 60, it is more certain that you're dealing with fat and not with partial volume averaging. But you also be mindful that there are several hematomas. They are lipid poor and they do not demonstrate fat on CT imaging. Then you have to go with the morphology, the lobulated borders, and the fact that these are stable for a long period of time is very reassuring to suggest hematoma. The other important sign is dilated bronchus sign. When you see a dilated bronchus with focal bronchiectasis with surrounding ground glass opacity, some tend to call it as scarring, but I want you to be mindful of the fact that adenocarcinomas can elicit desmoplastic response that causes dilation of the bronchi. So this is to be something kept in mind Don't call all these nodules as inflammatory scars. Intrapulmonary lymph nodes are something we should be aware of because these are benign. They are very common. The clue is the shape and location of these nodules. These are along the pleural surfaces, along the fissures, or within 8 millimeters of the pleural surface, and they usually have a round or triangular or oval shapes, and they are usually present in the middle lobe, lingula, and lower lobes. When you see this typical morphology, you can confidently say they are intrapulmonary lymph nodes. Even in patients with malignancy, it is not common to have infections, especially if you see clustered nodules in a small area within a lobe. Think about infections first. Don't jump to the conclusions that these are cancers. We see them very commonly, especially in the winter season when the flu time. This bronchiolitis is very common. The cavitary nodules are seen in typical malignancies. They are commonly described with squamous cell carcinomas and also with the metastasis from head and neck cancers, especially driven by papillomavirus. The urothelial metastasis, the transition cell carcinomas, also can have cavitary metastasis. This can be as a primary manifestation or after treatment, especially with bevacizumab or some other VEGF inhibitors. It is important to make a distinction between a cavity and a cyst. A cyst is defined as a round circumscribed space that is surrounded by a thin wall around 1 to 4 millimeters in thickness. This can be filled with air or it can be filled with fluid. It is also important to separate a cavity from cyst. I want to introduce the concept of cystic lung cancer. This has been seen more and more frequently in the era of lung cancer screening. A cyst which has got irregular borders, mural nodularity, is actually a variant of lung cancer. This should be atypical for metastasis, and it is also atypical for emphysematous bulla. Over time, this can become more solid and they become more like adenocarcinomas more commonly. In the meta-analysis we did, we combined all the data in the literature, and we found that cysts are not uncommon, and there is a clear way where these cysts evolve. And one of the, or the several possible mechanisms. One is the check valve mechanism, where a tumor cell occludes the bronchus. It causes dilation of the distal secondary pulmonary lobule. It can also be because a cancer is developing in a pre-existing emphysematous change, or it can be cystification. A solid nodule suddenly becomes like a cyst. So these are different etiologies that are proposed. We have some pathological proof for some of these cases. When you look at the pulmonary nodules, there's a long differential for solid nodules, a very long differential for subsolid nodules. So I'm not going to go into all the details, but I want you to remember one thing. The Fleischner guidelines do not apply for nodules that are seen in patients with established malignancy. So these are not applicable. So we cannot use Fleischner guidelines. Therefore, the management algorithms for these nodules becomes quite challenging. So the nodule management is, the nodule has to be entered by a person who has experience in looking at the nodules, look at the temporal stability, and we triage the nodules into actionable nodules and those requiring only imaging follow-up. All the actionable nodules are taken up by multidisciplinary clinics, and when you go to the multidisciplinary clinic, there are a few things we consider. The first is, what is the stage of the primary cancer? What is the histology? For example, somebody has lung nodules, the patient has a DCIS. These are more likely unrelated to the DCIS. We don't even consider them to be a possibility. Similarly, a lung nodules in the presence of stage 1 cervical cancer or colon cancer has no chance of being metastasis. So we can ignore those things. Similarly, the histology is also important. Very indolent cancers, basal cell carcinomas, they tend not to metastasize to the lungs. So this is also important. Finally, we also take into consideration the treatment history, the lab values to come out with a reasonable differential. So I want you to understand the concept of transient versus persistent nodules. Many nodules are transient, they disappear. This is particularly true for subsolid nodules. In one study, up to 70% of subsolid nodules have resolved on follow-up imaging. These are more likely to be transient in young patients, patients with have blood eosinophilia, patients who have irregular nodules, and many nodules. So these are some of the clues to suggest these are probably transient nodules. So this is an example of a patient with colon cancer, had a speculated nodule, part solid. We did a just 4-month follow-up. The colon cancer was in early stage. After 4 months, it completely dissolved. So this is what happens for most of the subsolid nodules. The role of FDG PET imaging for nodules in a setting of malignancy is somewhat controversial if the only finding is a lung nodule, because the nodules have to be of certain size for us to figure out their FDG uptake, first thing. Second, it also depends on the histology. Some metastatic nodules, say such as from prostate cancer, pancreatic cancer, may not be FDG avid. At the same time, ground glass nodules, which are adenocarcinomas of the lung, may not be FDG avid. So these are some of the pitfalls. So we use PET, but it is more useful for findings other than small lung nodules, such as, say, lymph nodal metastasis, bony metastasis, liver metastasis. It is probably more useful. More and more commonly, we perform percutaneous biopsies or some other sort of biopsies. What are the indications for biopsy? 1, to make a diagnosis of the nodule. 2, we want to determine the genetic alteration that is driving the cancer. Then in a patient who has completed the treatment, responded to treatment, if the nodule is coming back or growing back, we want to do a repeat biopsy to understand the underlying genetic alteration. The procedure of choice is mostly the least invasive. For all the central tumors and nodules and masses, we tend to do bronchoscopic biopsies. We reserve percutaneous CT-guided biopsy for peripheral tumors, and VATS also has a role, especially if you see multiple micronodules which are present in the setting of lymphocytic carcinomatosis. These patients are better served by either bronchoscopic biopsy or a VATS biopsy. When you do percutaneous biopsies, we always use coaxial technique. We use 19-gauge needle to puncture the pleura. We prefer 19-gauge because the hole we make is small enough, so the risk of pneumothorax is not increased. We take our FNAs with 22-gauge, and we take core biopsies with from 20-gauge needles. We prefer to have on-site pathology because the lungs are delicate, the nodules are small, we may cause problems, complications. We want to make sure that we have adequate samples so that we do the procedure once and we get all the answers. So there is some special situations I want to talk about. Nodules in a compromised host. These patients tend to have neutropenia. They also tend to have lower platelets. Putting a needle in these nodules is tricky. They may end up with severe complications. We tend to correlate with lab values and the treatment these patients are receiving so far as part of their treatment. So the two things would be focus on neutrophil counts. So I'm going to show you one example. Patient has 2 nodules, one in the right, one on the left, and I want you to follow the neutrophil count. When the neutrophil count is very low, neutropenia is technically less than 500 neutrophils. When the neutrophils are below that level, these patients are more susceptible to develop angioinvasive fungal infections, especially if the galactomycin is also high. When the neutrophil starts increasing, these patients develop cavitation, which is a good sign because the neutrophils are coming back. And the neutrophils, when they reach adequate levels, the nodules start shrinking. So you have to correlate with the neutrophil count to assess the nodule morphology. In nodule in the presence of a known lung cancer is also important. If the nodule, which is a tumor, is located in the same lobe as a primary tumor, is a T3 tumor. If the nodule is located in a different lobe of the same lung, it's a T4 tumor. Whereas if the nodule is located in contralateral lung, it's a metastatic nodule, which is M1A. The treatment for these 3 types of nodules is totally different. The second concept is if patient has got 2 distinct tumors in the lung, each with different histology, each is considered as a separate tumor, each gets its own TNM staging. So this could technically be one primary, one tumor nodule, therefore it could have been a T4. But instead, because there are 2 distinct primaries, Each are stage 1 cancers, T1, N0, M0. The final slide I want to show is multifocal adenocarcinomas. These are similar histology. There are multiple ground glass nodules. These are usually adenocarcinomas. When you have so many nodules, we do not chase or give a staging for all these nodules separately. We choose the largest nodule. We assign the TNM staging for that. Rest are just called the number of nodules, that's it. Thank you.
Your presentation on the approach to lung nodules in oncology cases was exceptionally detailed and thought-provoking. Thank you for sharing your expertise and for enhancing our understanding on this nuanced topic. Thank you, sir. How can we not include a topic on newer advances, something that's transforming almost every single field? Our next topic is about role of AI in oncologic imaging by Dr. Zaim Sia, Chief Medical Officer, Shanghai United Imaging Healthcare. On to you, sir.
All right, I need to hold my laptop. Good afternoon, ladies and gentlemen. Thank you very much for having me here, sharing our experience of AI in oncological imaging. As Dr. Diva Shah talked about a necrosis of the jaw, that reminds me more than a few years ago, that I did a lot of necrosis of the jaw reconstruction after the use of bisphosphonates. So right now I have joined United Imaging as a staff, chief medical officer, and all the products that, or applications that are presented here are not necessarily CE marked or FDA cleared. So be aware of that. Thank you. So my little bit background is I've been oral and maxillofacial surgeon and a craniofacial surgeon for 35 years before I joined United Imaging Intelligence. So let's talk about AI. Actually, it transforms the radiology and revolutionized the modern oncology. Now, number one is the streamlined certain clinical tasks from the scanning to analyzing, reporting, archiving, printing. Finally, it's a clinical circle that's been pretty well defined. Now, it also overcomes the limitations of the human sensory system. Look at the top image. It says, "Where is Waldo?" It's a famous American cartoon, right? And look at the image down below. Is where are the lesions? Either pulmonary nodules or fractures or mats. You name it. Where are these things? Even it's a difficulty. You're counting for the correct number of each ribs after hours and hours by readings. It's a little bit challenging. So nowadays we have 15 AI portals and more than 100 AI applications. And I highlight these two boxes is if we look at the bottom one, it's actually that's not product, well that's not portal. It is called a next generation cross-platform for unified solutions. By saying that is basically the foundation models to build all these AI applications on top of it. And our first AI application built on top of the large foundation model is the UAI Insight that I would introduce to you momentarily. So our portfolio encompasses 3 components to enhance the clinical workflow, to support biomedical research, and to enable the medical equipment. So first of all, talking about to enable the clinical workflow. We probably have built the most comprehensive solutions of medical imaging AI in the world to advance the medical AI. Not only to actually advance the technology, but tremendously helping radiologists, helping physicians, clinicians, also helping patients. Covering from head to toe, from neurology, cardiology, thoracic radiology, oncology, and et cetera, MSK, you name it. All of these applications being made based on the concept of, number one, is vendor-neutral integration that fully compatible with all the imaging modalities and the PACS-RIS system. Number two is browser-server architecture, that there's no on-site client-side installation that is needed. And finally, all these algorithms being scientifically and clinically validated. Question number one. Does the AI help radiologists? I'm going to play a 1 minute, 9 seconds video. See what the radiologist is saying.
In China, Shanghai 6th People's Hospital is better known for orthopedic injuries, and the radiology department has a huge volume of business. In terms of fractures, especially rib fractures, we may encounter 70 to 80 cases, or even close to 100 cases per day. Each patient image has to be split into thin layers. And the approximate volume of images for one patient is between 600 and 800 images. Therefore, the workload of relying solely on doctors to read the film is huge. With the adoption of UI's products, the workload for reading films is reduced exponentially. We are now relying on this product to a certain extent. Including some patients with rib fractures, we may let the AI do the calculations first, and the doctor will do the final diagnosis and confirmation, which greatly shortens the workload of our doctors per unit of time. And this is the shining point of the product.
Actually, AI can act as a first reader, and the radiologist act as a reviewer to review what AI tells you. That probably is an ideal situation, right? So now here are the, in the next few slides, I'm going to talk about a few examples of the solutions that we built. This is the stroke platform from the cellular film triage to ischemic stroke, hemorrhagic stroke, to CTA, to MRA, and to MRP perfusions. Here's an example of neuroscience that we would be able to one-click to process all these MRI images within a matter of minutes. Here are the examples of cardiovascular multimodality platform covering from not only the CT, CTA, but also cardiac MRI, CMRs. Oncological solutions, of course. Then we talk about the pulmonary cancer screening or diagnosis, plus the metastasis diagnosis. And thoracic solutions covering from lung, bone, and mediostems. The reason I bring in this as the last one is in the next few slides, I'm going to talk about U-Inside application that is basically built on top of the foundation models. Now, the UAI Insight, it is the medical agent for radiology. And I will talk about what is the agent, what is the large models in probably 5 minutes down the road. Okay, so this AI application watches the images on the findings, that watches the findings from the images to make an initial version of the report. Then listens what the physicians have to say to refine the reports. And finally, the large language model comes in to think and to restructure the entire findings and impressions and make a final report. So basically, the model here is to watch, to listen, and to think. Now, during nowadays, even with the Visage PACS system, still the viewers and the reporting writing system, they are still separate. The RIS and the PACS, they are two different systems. They are not sort of necessarily connected. Now, with the Insight, we designed it towards the holistic AI native system, yet it still is an add-on system, not truly the AI native PACS RIS system, but it's towards that direction. And there is a close interaction between the PACS systems and the RIS systems. Now, here are the examples. For example, the agent pops up and we click the hyperlink that is created by a draft by AI, and it will automatically take you to the image layer where the lesions or findings are located, or the little yellow box that will give you the lesions. Now, on the other hand, from the image back to the RIS system, we do the measurements on the image and automatically inserts it into the report. And that's sort of the interaction that regular risk packs never had before. So for today, we have the chest CT reporting. One scan, one pass of the AI detection, we would be able to detect 73 findings on chest CT. On MRI, brain MRI, we would be able to detect 32 findings in one pass in a matter of a minute. Here is what a physician or radiologist say in the most recent WEC meeting, World AI Conference 2025 that happened in Shanghai in July. Let's see what the radiologist is saying regarding this thing.
Today, we are presenting an agent that can perform multiple scans with a single chest CT scan. It can detect all 72 diseases of the chest. The overall accuracy rate can achieve 85%. So I believe that AI is definitely more efficient than humans.
More efficient than humans. Absolutely. I do agree on that. I'm a very conservative surgeon that, patient safety is always the first priority. I believe everybody sitting here is the same feeling. But AI can really speed up radiologist workflow. And that's also my belief. Oh, sorry. Now, for the PET CT oncology, we have listened to all these PET CT imagings. Now, the story went back about 15 years ago. I treated a patient with osteofibrous dysplasia patients with a big face. So we shaved it off and sent it for pathology as a routine. And pathology came back, osteosarcoma for a young 15 years old kids. I was like, wow, shocked. Sent him for a PET CT scan. The report came back is this book, thick, like 30-some pages, thick book. So I called up the nuclear medicine physician, my friend, Dr. Brian Butler. Hey, Brian, how do I read this whole thing? He said to me, read the first page, and that's the most important page, give you the overview of the MIP image, give you the overview of the cancer spread. And number 2 and number 3 pages, talking about findings, and then you look at the impression. And that's all you need to know, being a surgeon. So he threw me off the roof. You're not a surgeon, you don't have to read all of that. I said, Brian, how many minutes you create this whole book for me? He said about 2 hours, 1 hour, 30 minutes, 2 hours to assemble this book. Think about this. A nuclear medicine physician spent about 2 hours, 1 hour, 2 hours to create this book that clinicians or surgeons only read the first couple of pages. So when I joined the United Image Intelligence, I actually forced my scientists to work on this fully automated process of reporting. And here it is. That is the plus method of doing reporting. Physicians pick the lesions that you want to report and automatically add into reports. And let me play the video again. See, that's the ad. You check, you pick, and then you send it to report. Then it's building the report, and that's the image finding, and you see the bottom, there is a little button here. It's AI button says you click, then you from the image finding automatically generated impressions for you. And then all the images and screenshots and descriptions are fully automatically assembled. Like the book that I used to read, about 30-page thick book, in a matter of few minutes. And number 2 is the MIP image that allowing me to have the MIP image right here linked to the findings. Click the uptakes, and I see the descriptions on the image finding panel down below, and vice versa. And it also distinguishes biological versus pathological uptakes. SPEC CTs, the reason for doing SPEC CT is this, diagnostics. So for now, we are able to start off the fully automatic diagnostics, fully automatic inclusion-exclusion criteria, AI-based tumor heterogeneity analysis. Now, we are currently working on a fully automated dosimetry. That will come out about in a matter of a few months. Surgery. I'm a surgeon. I always want to see something recon that I will be able to talk to the patient. I need to be able to apply my surgery, and those are the QR codes that patient can scan on a cell phone, and he can look at it on his cellular phone. And this is one thing, it's a new adventure that we just built. It's an AI agent or Maris for the OR that is immersive virtual visualization without the VR goggle. Think about this. Dr. Diva Shah talking about the reconstruction of necrosis of the jaw. And oftentimes we use fibula reconstruction, right? So the most important for the fibula flap is the perforators. If the perforating vessel being destroyed accidentally during the surgery, the whole flap is useless. So that way we need to pinpoint the fibula flap, the perforators of the here. Probably the image a little bit too small. So with the gadget, we call it the Maris system, a metaverse ecosystem for robotic intervention therapy and surgery. And we did the surgery about a year ago back to University of Hong Kong, where I was trained about 20 years ago, in the same sitting room, same OR, with same, everything is the same, except people has been changed. And the person sat next to me is my student level. I mean, he is now the boss of oral surgery in chairing University of Hong Kong. The girl sitting next to her is his student, and she is hers intern. Think about it, generation by generation. And technology moves on, although the hardware, which AKA the room, stays the same. Now, biomedical research. Person like me, I know how to cut the patient, treat the patient, but I don't know how to write the software. So the system allows me to use my own data without programming it, do my own large model research or deep learning model research. And this one has mainly 4 major components, from data repository to smart annotation, model construction, validation, and finally built-in stats. And also have some dedicated AI toolboxes covering from neurology, nuclear medicine, down to liver MRI, CMR, et cetera, et cetera. And the clinical portal and research portal, they're sharing the same platform. That means we can build one application that being used for 2 platforms. Think about this. Just think about this. The application is a container. And we have 2 truck engines. One is designed for going highway, super fast, streamlined clinical portal. And the other one, truck engine designed to climb the hill. You can go through the zigzag road, but you can do everything that you want, but not streamlined. Each one has its own purpose. Research. Look at our competitors' performance. We want to be on top of everybody. Medical equipment, that I'm not going to dive into everything. Each piece of metal, each piece of metal guy that has AI component of it. And also we have the digital twins for deeper equipment inside for deep management. Those kind of things that we have to. Government regulatory compliance, we have more than about 30 CE clearance, CE marking and FDA clearance and NMPA, Chinese FDA. Finally, I spent 3 minutes, try to finish in 3 minutes, talk about a foundation model and AI agents. See, look at this. Can you tell me, is there a hallucination there? Because I'm the gold standard. I was the one doing the VSP. I developed the standard of care in the United States, okay? So the large model told me Dr. Peter Gattino, but his actual name is Dr. Jamie Gattino, okay? Nobody knows except me, but that's kind of a hallucination that you will see. Tell me, can you see the hallucination here? Dr. Sharhawk. I never knew him, but I Googled him. He's an oral surgeon. I never worked with him. But he says, I'm working with him. Come on. Okay? But this one is correct. In the summary, that's the correct one. So you don't know oftentimes which one's hallucination, which is truth. Last year, there is a publication on proceedings of a National Academy of Science talk about the concerning capability of large language models. Number one is the ability to understand it. Number two is to induce deception strategy. Wow, something very significant. But you saw the examples that I showed you, right? Because I know the ground truth of all these questions that I asked. And you will never know which one's true, which one's fake. So, bearing this in mind, we have created 5 foundation models: the large image model, large language model, large visual model, large speech model, and by combining all these together, we made multi-model model. We call these our foundation models. So now talk about what's the model, large model, and what is the agents. The large model is the large model training the large model to specialize in medicine. That's called medical large models. Now, the large model, we need to train the large model to think critically like human, to understand and reasoning why you give this answer. They need to know why they give you this answer. Now, for the agent, from that we need to make the medical large models to the medical AI agents. The action is the perfect term that is being used for the AI. Think about an FBI agent or IRS agent. They're not sitting down there just talk to you. They take actions. You don't pay tax, right? Okay. They fine you. They put you in the jail. FBI, criminals. Capture the criminals. And the agent, same thing. So react is the one that we are using, is to reasoning from the medical large models and action from medical AI agents. So now we talk about agents. The cognitive center is all these medical foundation models. Building on top of that is the medical agents. And building on top of that, again, then that is the medical applications that we are building upon. So now we are building diagnostic agents, surgical agents, medical service agents, hospital management agents, and educational agents. And finally, we are making a meta hospital with these data source that is capturing from not only the United Imaging equipment, but also our partners, ecosystem partners. Data. Then we develop the systems of data and knowledge, which is data as a service, and also knowledge as a service CAS. So these are the two protecting, this layer is a protection in order to prevent or to the maximum degree to protect the hallucinations. Then on top of that is the large models that we talked about and the AI agents that we talked about. Finally, we have on the top layer that users are going to be able to interface is, for example, Meta EMR that serves for the ER, for the inpatient clinic, inpatient service, outpatient clinic, etc. And also the AI PACS, that means it's a meta radiology per se, and embodied intelligent diagnostic equipment, for example, the clinical lab, also meta pharmacy. Finally, the HRP and hospital management. Without that, with all of that, then we think that is the future of the meta hospital that we are working on. To conclude, we have 15 AI portals and more than 60 applications designed for physicians being deployed, more than 4,000 hospitals and about 20 countries worldwide. And all these achievement publications. But we are not going to go anywhere without the folks sitting down there in the room with the clinicians, radiologists, the surgeons, internists, you name it. And finally, I just bring this up. Dr. Marcin Sternik, a Polish radiologist, he said to me, he cannot help himself not to write posts on the LinkedIn how great AI that thing is. Thank you very much for your attention.
Thank you, sir, for your insightful lecture, illustrating how the integration of AI with radiology will shape the future of healthcare. Now I'd like to open up the floor for a brief discussion.
Dr. Zio, I think it was a wonderful presentation. Probably I would have a couple of questions if there are no questions from the floor. Number one thing that I've always keen is using AI in diagnosing lung nodules in the X-ray. I mean, CT scan is pretty obvious, and we have very good radiologists, but sometimes X-rays are read only by the ordering physicians. So that's a place where we might actually be missing nodules, and then retrospectively we might pick up one or two. What's your experience about the AI in X-ray diagnostics of the nodules?
X-ray probably is not the best modality for screening lung nodules. That's my opinion. Because AI needs to see the things that a human being can eventually see. AI cannot create something that human have absolutely no idea whether it exists or not exists. And to today. Okay, to today.
There are several applications out there which are very good at picking up findings on X-ray. Just like a beautiful lecture from United where they found 73 findings, there are several models which can detect up to 216 findings on chest X-ray. The findings include pneumothorax, fractures, consolidation, cardiomegaly, pleural effusions. It also includes nodules. There are several products out there. There's actually one Indian product called Cure AI, which can read the chest X-rays. There's a software which is capable of picking up tuberculosis findings, which can be very useful. So nodules can be detected. But in general, X-ray is an inferior modality compared to CT for picking up the nodules. The size threshold for chest X-ray is much higher. Therefore, it's a challenge. But we are comparing two different modalities. But the X-ray is the only modality you have. There are also AI applications which are capable of picking up several findings.
Of course, I understand that when you suspect a nodule or someone to have a nodule, we wouldn't go for an X-ray, but then X-ray being taken for a different purpose, but then, they don't concentrate on the nodules that gets missed, but then eventually down the line, then you find a nodule, then you go in the CT scan, and then you go back retrospectively and see that they had a chest X-ray done for a different reason, and then there was a nodule. So that is a scenario which I was mentioning. That was great. And the other question is, I know that you have done enough and more with the AIs. Have you ever encountered situations where the clinicians or the radiologists have overlooked a subtle finding or sometimes significant finding because that has been read by an AI already?
This is a different question. So if AI is adopted into clinical practice, how does it affect radiologists, and how does it even affect the medical legal system? So if AI says something, this is a fracture or it's a nodule, it needs more confidence for the radiologist to rule it out. You would rather say, okay, probably there is a nodule, probably there is a fracture. That is a natural tendency. And there are some interesting incidences in US law system where jury actually wanted the radiologist to agree with the AI software, because somehow they believe that the jury believes that the AI is more sophisticated and more accurate. So this is some of the things we have to deal with them as the AI gets incorporated into the practice. At this time, it is difficult to say whether AI is always right and what is the consequence if you overrule the finding which is detected by AI.
My question was the other way around. I mean, AI has missed a finding, and then what do you think the mindset of the radiologists are, because it has not been picked up by the AI, whether they're going to miss something or they're going to find something which has been missed by an AI?
The first thing is all the AI findings, there are a lot of false positives. So when I'm a radiologist, I assume that the AI would not pick up all the findings, one. Then two, I also know that it picks up a lot of false positives, so I'll be able to rule it out. So as pointed out, AI is like a virtual assistant, like an assistant resident. It gives you a report, then you go and check it. It's not always 100% accurate. That is why a radiologist has to oversee the findings of AI and confirm it. So.
Thank you so much. Please allow me to add one point is, if you remember the PET CT that we showed, there is a particular video on the lower right hand. We used adding method rather than subtraction method. The reason for that is AI detects all these lesions fully automatically. Let's say you have a pulmonary nodule across 3 layers of 3 CT slides. It comes 3 positive findings, but in the PET CT, you don't want to report 3 times for a single nodule, right? So that's why we use add. Now, on top of that, the false positives then the physicians look at this thing, that's false positive. They just didn't pick it. So that is the reason we prefer add rather than subtraction method of creating reports. But even though you add without using fully automatic ones, you can also screening this thing probably in a matters of minutes, a few minutes, not a few hours. And once the screening is done, your screening is done, the report is automatically assembled.
Thank you so much for both the speakers for excellent presentations. I have just last question for Dr. Suba, that you have shown excellent follow-up interval images for various sizes of nodules and various etiologies. So when we are dealing with looking for a nodule with a malignant looking nodule in a lung cancer, solitary nodule, and you have shown one case of a stage 1 lung cancer. So what other clinically relevant information would you like to give to the surgeon or the clinicians apart from the nodule, like which help him in operability of that particular nodule? Because when there is one solitary nodule and surgeon wants to operate it, instead of just doing a biopsy when the size is very small.
Yeah. So if I understand correctly, we are reporting a nodule which is suspicious for a cancer, and somebody is planning to do a surgery. So how are we going to help him? The most important thing is describing the nodule accurately. And nowadays the trend is for minimally invasive surgeries. They do a VATS surgery. So in that, VATS has some limitations. It cannot resect all the nodules. The nodules have to be peripheral along the pleural surface. A nodule which is deep in the lung cannot be wedged out. So it basically requires a segmentectomy or a lobectomy. So by describing the nodule carefully, where it is located, in terms of the distance from the adjacent pleural surface, that will be very helpful for the surgeon. That's the first thing. The second thing is, if the nodule is too small, we can also help them by placing some fiducial markers, so that these are difficult to palpate. When the surgeons are resecting these lung nodules by wedge resections, they have to feel it. A solid nodule is easy to feel, whereas a ground glass nodule is difficult to feel. And even for solid nodules, if it is very small, it is very difficult to feel. So in those cases, we can put a needle close to the nodule, not exactly in the nodule, in the vicinity of the nodule, to place two fiducial markers or some sort of a localizer. And in the operating room, the surgeon can see under C-arm, they resect the wedge. After they take out the piece of the wedge, they do a radiograph, just like what we do for mammo, localization. That is something that can be done. So if the surgeon is doing a VATS, it is very important to know which segment it is, what's the distance from the surface of the pleura.
Thank you. Thank you so much for both of
Thank you. That brings us to the end of discussion. We thank our chairpersons and the speaker for answering our questions. Next up, we've reached the final session of today's scientific program, and to lead us through it, we have the pleasure of welcoming our chairpersons, Dr. Anandan, Senior Consultant Urologist, KMCH, Dr. Chandra Mohan, Consultant Radiologist and Academic HOD, Sri Ramakrishna Hospital, Dr. Anbakani Subayan, Senior Gyneco-Onco Surgeon, KMCH. We welcome you to the stage. First up, to take us through the topic tumor mimics in gynecological malignancy, we have Dr. Atul Shinagre. Dr. Atul B. Shinagre, Vice Chair Radiology, Clinical Operation, Brigham and Women's Hospital, Boston.
Good afternoon, everyone. Welcome to this session. I have no relevant conflicts of interest. So as I was thinking about this session, I realized that mimics can go both ways. Sometimes benign conditions can mimic cancers, cancers can mimic benign conditions. So I figured instead of talking about just one or two, I'll try to combine them and just talk about mimics in gyne imaging. So we'll talk about some incidental or some symptomatic lesions that are common in female pelvis, and those lesions are commonly seen. And the goal of imaging is timely detection of cancer, appropriate follow-up imaging or management to, so that the patients are correctly managed, and to avoid unnecessary imaging or surgery. And why does it matter in clinical practice? Let's take this example of a 35-year-old woman. She had no kids. She presented with pelvic pain. She was married for 2 years. They were trying to conceive. And this is what was seen. We are going to revisit this case later, but basically we see a sort of T2 hyperintense mass. It showed some diffusion restriction, enhancing mass. And the radiologist called it indeterminate lesion, but concern for leiomyosarcoma. Guy Nong said, okay, let's recommend hysterectomy. And patient was worried about the diagnosis, but also was distressed about losing the ability to conceive, especially given that the mass could be benign. So this is the kind of situations we end up with indeterminate lesions. So the approach will be case-based. This is not a comprehensive list, but a more focused approach. I don't want to talk about any rare cases or case report-like things. We'll try to focus on teaching points. And I have a few cases. If we run out of time, we'll stop there and skip to the end. So we have a 44-year-old woman with recurrent pelvic pain, and this is what is seen. Any quick thoughts, or at least keep your, think about what this could be. I have 4 cases of similar type, and then we'll talk about their diagnosis. This is another woman. She's a 25-year-old woman, incidental finding. The cystic lesion has 18 HU, attenuation, size is 9 centimeter. This is sagittal and coronal. Now case 3, 51-year-old woman, upper abdominal pain. There's a cystic lesion in the pelvis. We should also always look at the rest of the abdomen. So these are a few images from the rest of the CT scan. We see some findings in the peritoneum and elsewhere. This is the sagittal image. And then case 4, 71-year-old woman with abdominal fullness. We see this large mass in the anterior pelvis. That's the one we are going to focus on, not on the uterine finding. And this is the same mass on sagittal and coronal images. So let's go back to this. Any thoughts? Anyone wants to just take a quick guess? I think I heard something. So this is basically ovaries are sort of pulled medially. These are kissing ovaries. So this one was endometriosis with endometriomas. So we know endometriomas are heterogeneous. They're often multilocular, up to 3 locules, often bilateral and multiple. There's tethering of the organs. These are different few examples of endometriomas. The problem is sometimes they can resemble cancer. Sometimes there can be cancer inside endometriomas. And they're often difficult to differentiate from hemorrhagic cyst, which are unilateral, often unilateral. They're round to ovoid. Usually they have high attenuation material in them. They may have fluid level. And these are a few examples of hemorrhagic cyst. One other thing that I find helpful is sometimes there's a clot inside that has like a well-formed sort of concave surface. None of these examples have it, but we may see it sometimes. But this kind of fluid level is very common with hemorrhagic cyst. This one was a cystic lesion, and I showed you this is 18 HU. But if you look carefully, there are some areas of what look like nodularity. And if you put attenuation values on it, they're very small, so it's important to look at coronal and sagittal images. And if you put HU values on it, those are definitely higher than fluid. This was actually serous ovarian cancer. So carefully look for subtle soft tissue nodules, because sometimes these lesions can pass off as benign cyst, and a year later, the patient will come back with something bad. Review coronal and sagittal images carefully, and use smaller ROIs if needed, or you try ROIs in different areas if you think there's some solid nodularity. This is another example of multiple tiny sort of solid soft tissues. CT only has about 80% accuracy for diagnosis of these lesions, so we need to reduce false positives and false negatives. These are a couple examples of false positives where benign lesions are. We had this study where 9 readers scored these lesions, and these benign lesions were scored as cancer by some readers because either of the irregular size or this kind of retractile clot inside a hemorrhagic cyst. So sometimes we see benign high attenuation component, and we have to sort of look. Sometimes it's just not possible to diagnose it on imaging, and we have to get further imaging. This is one example. This is somewhat avoidable. sometimes we see a lesion and there is a little bit of nodularity in its wall. Now, this is a very small lesion, and maybe somebody thought this is preserved ovarian tissue adjacent to the lesion. But anytime there's a nodularity protruding inside the lesion, we have to think carefully and see if this is actually cancer. So this was missed internal nodularity and missed cancer. This one has a lot of peritoneal stranding, but if you look carefully, and it's hard to see on few images, but the pancreas is heterogeneous. Patient had upper abdominal pain. This actually ended up being simple cyst and in a patient with pancreatitis. So just because you see peritoneal findings, that doesn't mean they're always related to this adnexal lesion. So if you see just ascites, we definitely don't want to just assume this is malignancy. Peritoneal stranding can be a little bit more worrisome, but can also be seen with any peritoneal inflammation, colitis, and things like that. If you see peritoneal nodularity, then that is a bit of a worrisome finding. So peritoneal findings may or may not be related to the adnexal finding, and if related, although, that's a high chance of cancer. This is one example where there was adnexal lesion, which is irregular shaped, and there are multiple lymph nodes, peritoneal sort of nodularity, even a liver lesion, and this all ended up being cancer. And this one was actually ovarian fibroma. You have homogeneous soft tissue lesion. The thing is, you cannot diagnose it on CT. You have to ask for MRI in this case, but this ended up being a fibroma. So this was solid enhancing mass, and differentials would be fibroma, leiomyoma, or leiomyosarcoma, or other solid mass. And that's why you need imaging here. Sometimes it could be other way around. Now this was actually a malignant lesion that looked like a fibroid or fibroma. And that's the reason when you see something like this, it's best to get MRI, at least further imaging or imaging follow-up. All right, this next woman presented with uterine bleed. Now we see this soft tissue mass, and it has somewhat typical appearance. This was endometrial stromal sarcoma. So this is typically seen in premenopausal women, arises from the endometrium and infiltrates the myometrium. It has heterogeneous high T2 signal. The infiltrating it starts in the endometrium and projects inside the myometrium. So it has this kind of flowing appearance or worm-like low signal bands, and that's pretty typical. Sometimes it can be confused with polyp or leiomyoma or adenomyosis. But if you see appearance like this, that's quite typical of this endometrial stromal sarcoma. All right, this woman had history of endometriosis. She was pregnant, and on one of her ultrasounds, this was found. And there's another woman had known endometriosis, and this is what was found on T2-weighted images and post-contrast. There was no fat in this lesion, and unfortunately, DWF and ADC images were not evaluable in this case. All right, so this one ended up being decidualized endometrioma. Although we see this soft tissue nodule, decidualized endometrioma is a known sort of mimic of cancer. When you see a patient, especially with patients with history of endometriosis, this typically happens during pregnancy, often during second or third trimester. It may be seen as smooth mural nodules or papillary projections. There is vascularity on color Doppler. On MRI, it's T2-ISO2 hyperintense, enhancing nodule. This was another patient with endometrioma and similar soft tissue protruding into it, which was also proved to be decidualized endometrioma. And here, this was endometrioid carcinoma. You see this tiny enhancing nodule. So on T2, this was a large endometrioma. There was a soft tissue protruding into it, which was enhancing. And if you look at the enhancement curve, this was high-risk curve. There's sharp upslope, there's a shouldering, and then plateau. This is very typical appearance of something aggressive. Although this was a small lesion or small amount of soft tissue, this was endometrioid carcinoma. And so endometriosis-associated cancer can be either endometrioid or clear cell carcinoma, often seen in women 40 years old or older or postmenopausal women. Usually this is seen in long-standing endometriosis or large endometriomas. Irregular mural nodules or papillary projections are common. There may be thick, irregular septations. These are usually T2 ISO2 hypointense with early intense enhancement like the one we saw. And interval growth is another indicator, but ideally we would like to detect them early. And when you see this, next step is to look for peritoneal nodules or lymph nodes to see for any signs of spread. So now next person, these are the T2 weighted axial images. There's a lesion here. Same on sagittal images, T2 sag. She had pelvic pain, elevated CA125, diffusion and ADC, and post-contrast, sagittal and axial. Any thoughts? So, considering that this looked like soft tissue, there was diffusion restriction, elevated CA125, this was actually read as potentially cancer. Patient went to surgery and they ended up draining a tubo-ovarian abscess. So, couple of teaching points here. First, absence of fever. I did not give a history of fever here. You'll notice this was just pelvic pain, elevated CA125. If you see history of fever, the diagnosis becomes pretty obvious. But fever may not always be present in patients with tubo-ovarian abscess, especially those with subacute or chronic disease, older patients, uncontrolled diabetes, immunocompromised patients, and those who have received prior antibiotics. There may not be fever. This was another example of salpingitis mimicking neoplasm. This patient had a little bit more typical findings, but the imaging findings were confusing. Then the other thing in this patient was elevated CA125 level. Because elevated CA125 is non-specific. It may be seen with gyn cancers, ovarian cancer and others. It may be seen in non-gynecologic cancers like pancreas, HCC, or breast cancer. It may be seen in some benign gynecologic causes, especially pelvic inflammatory disease, tubo-ovarian abscess, endometriosis, even functional cysts. And then it can be seen in some benign non-gyn causes, especially peritoneal inflammation and peritonitis. And then by that extension, pancreatitis, enterocolitis, that can cause peritoneal inflammation and elevate CA125 levels. If the values are very high, or in postmenopausal women, then it's a little bit more specific, but you cannot simply rely on CA125 levels. It's not so much useful for screening for ovarian cancer, but it's more useful for monitoring for known ovarian cancer. Now this young woman had amenorrhea. And you see this T2 hypointense finding involving both the ovaries more on left side. There's no diffusion restriction and very mild enhancement. So sometimes this may appear mass-like, but this was ovarian fibromatosis. Usually this is basically spindle-shaped fibroblast and collagen around preserved follicles, seen in young women, often bilateral. It may present as a mass, but more often menstrual irregularities. And we see these peripheral follicles with mass-like hypoechoic stromal thickening. It's low T2 signal because of fibrosis, minimal enhancement. The differential can be polycystic disease or fibroma. But the key finding is this preserved follicles in it, just like was seen in this case. Now, this woman had prior morcellation of fibroid and now presented with these multiple T2 hypointense masses throughout the peritoneum. This was the largest. It had no diffusion restriction and mild enhancement. So the question becomes, is this the greatest fear behind morcellation is leiomyosarcoma spread? So that's the concern. But this was actually just multiple parasitic fibroids. But because of leiomyosarcoma concern, these were actually biopsied. Now, this woman had pelvic pain, history of AML, acute myeloid leukemia. And now on CT, there was some kind of soft tissue next to the uterus. So MRI was obtained. There was uterine fibroid, but there were these soft tissue masses. Any thoughts what this could be? Anytime you have patient with AML with soft tissue masses anywhere, you have to think of myeloid sarcoma, or what was previously called chloroma or granulocytic sarcoma. This is basically deposits of like AML cells, and this can happen anywhere. It can happen in skin, bone, soft tissue, wherever. And this usually portends poor prognosis. So if you see a mass in AML patients, you have to raise this possibility. Now, when you see ovarian mass, like in this case, there was incidentally seen mass on CT, then MRI was obtained. This looks like a malignant lesion. But when we went back and looked at this CT, there was something here in the stomach. So this was actually gastric cancer with Krukenberg tumor. So anytime you see ovarian mass, don't forget to look for extra ovarian findings if you have any current or prior imaging. It's a simple message. Similarly, in this patient, there were ovarian, like FDG masses, but this patient had lymphoma involving the ovary. So these masses were actually just lymphomatous, not primary ovarian malignancy. Now, 74-year-old woman with incidental mass. Now we have this T2 sort of heterogeneous, some areas are T2 hypointense, some areas are intermediate or high signal. There's diffusion restriction, and there's some enhancement. So this is not typical appearance of fibroma. There's some enhancing mass. So obviously there's concern for something malignant. The degree of enhancement is less than myometrium, so it's a low risk finding. But when you put ADC values, the ADC is more than 0.9. So if you remember, there was a radiology paper about leiomyosarcoma. If there's a mass that has intermediate to high T2 signal, enhancement, restricted diffusion, and ADC values below 0.9, that is a concern for leiomyosarcoma. But in this case, this was actually also present 3 years ago, not change in size, and this ended up being a cellular fibroma. This kind of heterogeneous appearance can be seen in cellular fibroma sometimes, so something to keep in mind. On the other hand, this one, again, T2 intermediate to high signal, enhancing mass, restricted diffusion, and in this case, ADC values are pretty low. And this was leiomyosarcoma. Now, this pregnant woman had pelvic pain, and we see this T2 hypointense mass instead of the ovary. There are some tiny follicles at the periphery, but the pain was like recurrent pain, but this time it was very, very acute. And this ended up being torsion. Now, because she was pregnant, obviously we could not give contrast, but still, based on the history, pregnancy, we kind of had to raise the possibility. She actually went to surgery and the ovary was completely necrotic. But sometimes torsion can resemble a mass. Now, one other very common but mimic of cancer can be adenomyosis. Now, in this case, there are very typical findings. On T1 weighted images also, you can see those typical high T1 signal foci. On T2, this junctional zone is very, very thickened. There's heterogeneous high T2 signal foci. So pretty typical appearance, you just need to be aware of this possibility. Now, if we circle back to this patient, 35-year-old woman that we first saw, who was very concerned about her diagnosis, again, going by the same rationale, we looked at the ADC value. This was initially read as possibly cancer, but she really wanted to avoid hysterectomy. The ADC value was high, and we thought, you know what, maybe this is not leiomyosarcoma. Patient underwent myomectomy, and this ended up being cellular leiomyoma. So she was able to keep her uterus, and we got the mass out. So generally approach is, the mimics are pretty common. We need to know the typical features, correlate with age, symptoms, other clinical information, carefully evaluate enhancing solid tissue, look for any ancillary signs or non-gyne malignancy that can cause confusion. Prior imaging is your friend. Anytime it's available, make sure to look at it. Understand the limitations of the imaging modality and tumor markers. When necessary, judiciously use follow-up imaging or even biopsy if needed. And that's how we can approach these masses. Thank you.
Thank you, sir. Thank you for shedding light on the often tricky world of tumor mimics. Our next session is about mastering the transitional zone lesions in multiparametric MRI. Tips and traps by Dr. Dayala Sundaram, consultant radiologist from Apollo Hospitals.
So good evening all. For the next 20 minutes, I'm going to talk on mastering the transition zone lesions in multiparametric MRI of prostate. So this could be the best image to start a discussion on transition zone image, because many a times, irrespective of years of experience, we may find difficulty with all transition zone lesions in day-to-day practice. So the objectives, there are four aspects in this talk. First one is about the zonal anatomy and the challenges with transition zone. The second one is about the evaluation of transition zone lesions with the help of PIRATS version 2.1 guidelines. And third one is about the false alarms in transition zone. And fourth one is extra tools available for evaluation. So let us start with the basic concepts. There are four zones in the prostate we know: central zone, transition zone, peripheral zone, and anterior fibromuscular stroma. Let us explain with this schematic image. This is a sagittal image of prostate. So this is a prostatic urethra and this is the ejaculatory duct. So here this is the ejaculatory duct. So the portion which surrounds the ejaculatory duct is the central zone, and the portion which surrounds the prostatic urethra is the transition zone, and the one which is in the anterior aspect is the anterior fibromuscular stroma. So in axial sections we can clearly see that this is a prostatic urethra, and the one surrounds it is the transition zone, ejaculatory ducts, and the central zone, and the one which surrounds all these is the peripheral zone. In MRI images, this is axial and this is a sagittal image. Here, this is a prostatic urethra, this is a surgical capsule, and this is a peripheral or pseudo capsule. The one which surrounds the prostatic urethra is the transition zone, and the one which lies in between the capsule is the peripheral zone. Here in the sagittal plane, this is the place for prostatic urethra, this is the anterior fibromuscular stroma, and this one is the transition zone. Right. What is the disease load in the transition zone? The diagnosis differentials are very simple. In benign spectrum, we get benign prostatic hyperplasia and prostatitis, whereas in the malignant spectrum, it's almost always prostatic adenocarcinoma. What is the incidence? The BPH is almost occur in the transition zone, whereas the incidence of prostatitis occurs more in the peripheral zone than in the transition zone because of the increased vascularity. Right, this is very significant. What is the incidence of prostatic malignancy in the transition zone? Because many a times, the adenocarcinoma occurs in the peripheral zone, whereas the incidence in transition zone is 20 to 30%. Now, what are the challenges with the transition zone lesions? Why it is so important? There are two important challenges. One is inherent anatomical complexity of the transition zone. Second thing is add-on influence by the BPH nodules over the transition zone. So let us see this anatomical complexity. So in prostate, the histopathologically we can see that in the peripheral zone, predominantly it is made of glandular parenchyma. Almost 80% of the prostatic glandular parenchyma lies in the peripheral zone. Whereas in the transition zone, much of cellularity is there. There is so much amount of fibromuscular tissue and smooth muscle cells will be there. Only 5% of the cells will be glandular. So we know that if there is more amount of glandular tissue, there will be more amount of water content. So obviously the peripheral zone will be uniformly hypointense on T2 weighted image, whereas more amount of cellularity and stromal elements makes the transition zone more heterogeneous pattern like this. Right. What is the influence of BPH over transition zone? We know that almost 50% of the men in 50 years and almost more than 90% of the men over 80 years may develop benign prostatic hyperplasia. BPH is not a simple enlargement of the prostate. It is about the zonal redistribution. The transition zone disproportionately enlarges to the size of the prostate and it compresses the other anatomical structures. So how this BPH can affect the diagnosis of a transition zone lesion? There are three things. One is it can cause anatomical distortion. Second thing, it increases the complexity of MRI appearance. And third thing, it causes biochemical abnormality. So this is the various phases of BPH. We can see that in some of the prostate, we cannot even, the entire gland is occupied by the transition zone, hypertrophied BPH nodules and everything. Even we cannot see the peripheral zone at all. So in this scenario, we can come across two situations. One is there will be false negativity in the sense, if there is a small lesion, there is a small malignancy, early malignancy inside this transition zone, because of the benign prostatic hyperplasia, the nodules will compress the malignancy and the malignancy will be less conspicuous. So this increases the false positivity. Second thing, it increases the false negativity. And second thing, it increases the false positivity. The enlarging transition zone will compress the normal anatomical structures like this kind of central zone or the surgical capsule. So these structures will form a pseudo lesions. So this kind of false positivity will be increased with the anatomical distortion. Second thing, how the complexity of MR images increased by the BPH nodules. The BPH nodules may have predominantly glandular pattern, so the nodules will be hyperintense on T2-weighted image. Sometimes it may have predominantly stromal elements, so they may be hypointense like this. If it is a mixed bag, it may have a organized chaos pattern like this. So this makes the lesion detection more challenging. Right, how the BPH affects the biochemical structure, right? BPH is not only increasing amount of smooth muscle cells, there is increased number of epithelial cells also there. So these epithelial cells secretes more amount of PSA. So larger the gland, larger the secretion of PSA. So this leads to bias in the decision making, and we may tend to do a biopsy for a BPH lesion. So this increases the number of unnecessary biopsies. Now we are going to see the second portion, how to evaluate a lesion in a transition zone. Transition zone lesion should be evaluated in 3 steps. The first step, we have to localize the disease, whether it is in the transition zone or in the peripheral zone. Right. Second step, we have to do the scoring. If we confirm this lesion is in the transition zone, if the lesion is in the peripheral zone, we have to do the scoring based on the dominant sequence, which is diffusion. Whereas for the transition zone, the dominant sequence is T2-weighted image. Based upon this, scoring will be done. So we'll score from 1 to 5. In the final step, we'll do the final category assessment. So in this, the scores will be converted into PIRATS category. In transition zone, PIRATS 2 and 3 lesions should be further evaluated with diffusion parameter. So if a PIRATS 2 lesion shows a diffusion parameter of 4 or more, this can be upgraded to PIRATS 3. Whereas PIRATS 3 lesion shows a diffusion parameter of 5, this can be upgraded to PIRATS 4. So overall, when we assess this picture, we can understand that there is no role for contrast. There is no role for dynamic contrast enhancement in evaluation of the transition zone lesion. Let us see the scoring pattern. If a transition zone appears normal or there are typical nodules like completely encapsulated nodules, the score is 1. If there are some atypical nodules like mostly encapsulated or partly encapsulated nodules, they are score 2. Sometimes some heterogeneity may be seen between the nodules, that is also comes under category 2. Heterogeneous signal intensity with obscured margins, score 3. Lenticular or non-circumscribed homogeneous moderate hypointense lesions, size less than 1.5, score 4, size more than 1.5, score 5. And if a lesion presents with extraprostatic extension or invasive behavior, the score will be 5. Finally, if we cannot allocate the sum of the lesions in any one of the group like 1 or 2 or 4 or 5, then this can be accommodated in group 3, score 3. So finally, this score can be converted into PIRATS category. PIRATS 2 and 3 will be further evaluated with diffusion. This may look little complicated, this entire table, but we have some key words, something like nodules. So if you find a nodule, we can allocate, we are dealing with a lesion that will fall in under category 1 or 2. If you find a lesion that is showing heterogeneous signal intensity, then it's PIRATS 3 lesion. If a lesion is homogeneous signal intensity with non-circumscribed margin, score 4 or 5. Based on this table, we can come to an algorithm. If we find lesion at the hand, if it's a nodule, it's yes, the score is 1 or 2. It's not a nodule, score 3, 4, 5. If it's a nodule, then if it's completely encapsulated, score 1. Partly encapsulated, score 2. If 3, 4, 5, then we have to check for the signal intensity. If the signal is heterogeneous, then it is score 3. Homogeneous signal intensity, score 4 or 5. Score 2 lesion can be further evaluated with diffusion, and score 3 lesion will be further evaluated with diffusion parameter. So now it's time to evaluate the diffusion scoring. So how to diffusion scoring is done? We have to start with the ADC, then check with diffusion. So ADC and diffusion is normal, score is 1. Wedge-shaped or linear hypointensity on ADC or hyperintensity on diffusion, score 2. Discrete hypointensity on ADC or hyperintensity on diffusion, score 3. Marked hyperintensity on ADC, hypointensity on ADC and hyperintensity on diffusion, the size less than 1.5, score 4. Size more than 1.5, score 5. Now, with this tools, let us evaluate individual lesions. This is a 50 years old male, asymptomatic individual with slightly elevated PSA level on screening. So here, let us evaluate the transition zone. There is no nodules or no focal lesion. So this lesion, this is confined to score 1 because this is a normal transition zone. So score 1 lesion can be confirmed to Pirates category 1. Now let us evaluate some of the nodules. Let us see this nodule. This nodule is having a complete capsule. It is completely encapsulated. Whereas this nodule, it is hypointense and doesn't show any significant delineate capsule. Here another nodule, there is no capsule. The sagittal plane also we can confirm. It is unencapsulated. Similarly, another nodule is here. It is partly encapsulated and part of the nodule, this portion, the medial portion is not encapsulated. So when we categorize or score these nodules based on Pirates, this first one encapsulated is score 1, whereas these two nodules are score 2. So when we deal with the score 2 nodules, we have to definitely check with the diffusion parameters. Let us check. For this nodule, the diffusion, ADC is slightly hypointense, but diffusion, there is no restricted diffusion. So this will remain as Pirates 2. Whereas this nodule, partly encapsulated nodule, but it shows significant restricted diffusion. So this can be upgraded to Pirates 3. Now some caveats, like we day-to-day practice, we may find this kind of completely encapsulated nodule but shows significant restricted diffusion. So there may be confusion whether we have to follow the T2 weighted guidelines or diffusion. So many articles says that in these kind of scenarios, we have to follow the dominant sequence. So for a transition zone, T2 is the dominant sequence. So irrespective, if it clearly falls under score 1, then we should not consider the characteristics of diffusion parameters. So possible explanation for this nodule, some benign stromal nodules may show significant restricted diffusion because of increased cellularity. Second caveat, sometimes we may find this kind of T2 hypointensity in between the nodules. This is the axial plane, same patient, coronal and sagittal planes, we can appreciate the same hypointensity. Another similar T2 hypointensity in between nodules. Even if you check with the diffusion parameters, the diffusion will be normal. So these kind of hypointensities in between the nodules are nothing but compressed fibromuscular stroma. So these kind of T2 hypointensities should be under score 2. Now let us evaluate Pirates 3 and 4 lesions. There are two sets of images here. There is a lesion here, another lesion here, another set of lesions here. So when we compare, we can see this in these set of lesions, there is some homogeneity is there. So this is a better image because same location, there is some homogeneous hypointensity, whereas heterogeneity is clearly appreciated in all these lesions. So these heterogeneous signal intensity is in favor of Pirates 3 group, whereas this homogeneous signal intensity is in favor of Pirates 4 group. Let us evaluate Pirates 3 lesions. These are the lesions. There is a lesion heterogeneous signal intensity on the left lobe, whereas here it is in the right lobe. So we know that for a Pirates 3 lesion, we have to further evaluate with the diffusion parameters. So let us evaluate with the diffusion. Here in the upper row, there is no significant restricted diffusion. So this lesion will be retained as Pirates 3. Whereas in the lower row, this lesion shows significant restricted diffusion and the size is more than 1.5 centimeters. So the diffusion score is 5. So this can be upgraded to Pirates 4 lesion. Now let us check another indigenous Pirates 4 and 5 lesions. Here we already saw that lesion, the homogeneous signal intensity without any capsulation. Let us evaluate with the diffusion. There is no current recommendation for evaluation with the diffusion for a Pirates 4 and 5, but it is always safe to evaluate because all the clinically significant prostatic malignancies will definitely show significant restricted diffusion. So now the tiebreaker is the size. So if the size is less than 1.5 centimeter, it is Pirates 4. If the size is more than 1.5 centimeter, Pirates 5. Yet another lesion with the homogeneous signal intensity, but this lesion clearly breaches the extraprostatic fat plane and it enters into the erythropubic fat plane. So this kind of extraprostatic extension is in favor of Pirates 5 category. There are some caveats in the Pirates 4 or 5 lesions when we analyze the homogeneous signal intensity, because this kind of homogeneous signal intensity in these two lesions we can appreciate. This is because sometimes we may come across these kind of homogeneous signal intensity in patients with recurrent prostatitis or patient on hormonal therapy or patient who completed radiotherapy. So when we analyze these kind of homogeneity, we should never ever stick to the T2 weighted image. We should check the diffusion protocol. So here the diffusion is normal. So this is just post treatment changes. So this falls under category 1, whereas this shows significant restricted diffusion, and this comes under category 5. Now some false alarms in transition zone. First one is central zone. Central zone is a completely different thing. It's Wolffian duct derivatives. It is around the ejaculatory ducts. Normally a central zone will be seen as a T2 symmetric T2 hypointensity in the base. In axial cuts it is seen as a mustache sign, whereas in the coronal cut it will be seen as a triangular or teardrop sign. It will usually extend up to the level of Fairmont. Right. What is the problem with central zone? When there is a large amount of benign prostatic hyperplasia, this central zone will be compressed. So it may show some sort of asymmetry. So it may be mimicking like a transition zone carcinoma. So here is an example. There is a central zone. It's compressed to the periphery. So how to differentiate it from a malignancy? So even though central zone shows hypointensity on T2 weighted image as well as ADC, when we check the diffusion parameter, the diffusion will not be significant. There won't be significant restricted diffusion, or there won't be any significant contrast enhancement like a mass. Second thing is anterior fibromuscular stroma. It's a completely acellular fibrotic element of the prostate. It will be seen in the anterior aspect. So axial plane, it will be like this. But sometimes when it is thickened, it's a benign finding, but it may mimic like a malignancy in the transition zone as in these cases. So how to differentiate? These AFMS will show a hypointensity on T2 and ADC map, but when we carefully check the diffusion parameter or the enhancement pattern, it will not show significant restricted diffusion or enhancement like a mass. Third thing is extruded nodules. Sometimes there will be a lot amount of nodules inside the transition zone. Some of the nodules in the periphery may protrude into the peripheral zone. So here there is a nodule which is just protruding into the peripheral zone. Another example, a nodule protruding into the peripheral zone. One another example here. So the problem with these nodules, they will be showing significant restricted diffusion and even sometimes enhancement. So they may mimic like a mass or malignancy in the peripheral zone. So how to avoid this, we have to check the other planes. Like in this case, we can see a protrusion from the transition zone on sagittal coronal plane, whereas in this image there is a sagittal, when we check the sagittal plane, we can clearly see that the nodule is just protruding from the transition zone. Next one is the surgical capsule thickening. Surgical capsule surrounds the transition zone. Sometimes there will be disproportionate growth of the BPH. One side it will grow more and other side it will be less. So this kind of disproportion may cause some mechanical stress over the surgical capsule, and the surgical capsule may go for thickening, reactive thickening. So those kind of thickening may cause hypointensity on ADC. So these hypointensities may mimic like a mass. At another example, thickening of the surgical capsule seen as hypointensity on ADC. But how to differentiate within a malignancy? We have to check with the diffusion. Obviously, there won't be any significant restricted diffusion. And prostatitis is one of the important differentials, and here this is one of the area in which the transition zone we use the contrast imaging. So this is the T2 weighted imaging, contrast, diffusion. This patient presented with elevated PSA level and systemic complaints. Here the transition zone shows diffusely altered T2 signal intensity, and there is intense diffuse enhancement of the gland, but there is no significant restricted diffusion. This kind of disproportion diffusion restriction and contrast enhancement will be more common in prostatitis. Yet another case, there is prostatitis in the transition zone, but another thing is we can observe there is significant dotted appearance of significant restricted diffusion. There is only necrosis and peripheral enhancement. This is nothing but evolving abscess. Important thing is usually, however big the prostatic malignancies, they won't present with necrosis. This is an interesting case. This is a case of granulomatous prostatitis. Some ancillary findings may be there with prostatitis. We can have diffuse bladder enhancement and seminal vesicle enhancement or cord structure enhancement, something like this. So far, we have seen some cases with confined to the transition zone, but it may rise from the transition zone to the peripheral zone, or it may occupy the entire gland. For this, we have to use the diffusion parameter more. Finally, there are some slides with recent tools, 3 or 4 slides. PSA density is one of the important tool, because if a gland undergoes a benign prostatic hypertrophy, it may have a larger PSA level than if it contains a small malignancy. So to avoid this volume effect, we have to calculate the PSA density. It's nothing but the serum PSA is divided by prostate volume. The cutoff value is 0.15 nanogram. It's more important in gray zone of the prostate PSA levels when the PSA level is 4 to 10 nanogram. PSMA PET-CT is always a handy tool. We can use it when MRI cannot be done. And many studies nowadays says quantitative ADC and advanced diffusion parameters can be used to differentiate. Last slide. So to conclude, T2 weighted image is the dominant sequence for transition zone evaluation. PIRATS 1 and 2 lesions should be evaluated by capsule. 3 and 4 lesions should be differentiated by signal intensity. Diffusion should be always checked for all the lesions, and there is no role for dynamic contrast imaging in transition zone evaluation except for prostatitis. Finally, PSA density should be calculated for all the lesions, and if PSA density is elevated, it should be properly explained. So with this, I conclude my talk. Thank you very much for the patient listening.
Thank you, sir, for making the MRI prostate a lot easier. After that session, we are no longer lost in zones. So now we are open for quick comments and or discussions.
Both are excellent presentations, sir. I have if there is no questions from the audience, so I have a question for Mr. Dayalasundaran. Sir, do you routinely do contrast for your prostate studies, sir? As a routine?
MRI prostate, you mean? Yes, sir, we are definitely, because in multiparametric MRI, it consists of only 3 main sequences. Yeah. One is T2 weighted imaging, next one is diffusion, and third one is dynamic contrast imaging. But the role of dynamic contrast imaging is little less nowadays, because it is useful only in peripheral zone lesions, particularly when we find a PIRATS 3 lesion. If there is dynamic contrast imaging, we can upgrade that lesion to PIRATS 4. Otherwise, there is no big role, and we are nowadays even biparametric MRI is being practiced. So, if we cannot administer a contrast like elevated renal parameters and all, yes, we can go ahead with even biparametric MRI.
Otherwise, there is routinely use contrast.
Yes, routinely, if renal parameters are normal, it's better, because sometimes when we have some other it is vague lesions, something like that. So obviously, as a urologist referral will be mainly they want to know whether it's a malignancy or a prostatitis. So for prostatitis, definitely contrast is because the ancillary findings, many times prostate will be really confusing. Because all the things we are doing is all qualitative, not quantitative. We are not measuring anything. Everything is by eyeballing. So if we find some amount of enhancement in ancillary structures like bladder, some other adjacent structures also showing some inflammation with the help of contrast, will be useful.
Thank you, sir.
Regarding the nodules, if there are multiple nodules, usually in cases of BPH we have multiple nodules. In such scenario, how will you look for any specific lesions in the multiple nodules? How will you do the staging? And the other question is regarding the prostate size. If the prostate size is larger, does the sensitivity of the MRI in picking up the CA is less, or is the same, especially in the transitional zone?
Sorry, second question I couldn't get. It's about?
The sensitivity of MRI in transitional lesions.
Yes.
If comparing with the prostate size.
Yes, sir. So about the first question, it's about, sorry. First question
multiple stromal nodules.
Yeah, first, multiple nodules. So both in thyroid and the prostate, we may have nodules after 50 years of age. In thyroid we have thyroids, and prostate we have pyrites. Both systems in we have numbers. So up to 5 lesions we can mention. So according to PIRATS version 2.1, we can have the index lesion. So the nodule which has the higher PIRATS categorization will be the index lesion. Not about the size, but by the nature of the nodule. If we have multiple nodules, one of the nodules is showing less capsulation, or it's showing unencapsulated with a diffusion restriction. So that will be taken as an index lesion. But not necessary to mention multiple nodules. Practically, it is not. We are not doing it. And if we find all the other nodules, one nodule is PIRATS 3 and all the other nodules are 2, then we are saying that it is more in favor of BPH. And this nodule is comes under PIRATS 3 category. Either based on the history or PSA density, we'll do a biopsy or follow-up. So, guidelines says that we can mention up to 5 nodules. The one which has higher PIRATS should be the index nodule, index lesion. And about the second question, obviously yes, because the sensitivity will be less once the gland enlarges in size, because we can find more amount of glandular parenchyma. Even the other way, it is very important, because there are some theories that this hypertrophy also affects the peripheral zone, because since the transition zone compresses the peripheral zone, if there is a lesion in the peripheral zone, obviously that is also being that is also become less conspicuous because of the transition zone enlargement. So lesion reduction and sensitivity becomes less once gland grows out of the size.
My head is just spinning with all the parents scoring. I'm not a urologist, so I don't have any questions to ask you. I think we'll just congratulate both the speakers for the last session, for their brilliant talks, and for the very patient audience, and we'll end the session here. Thank you so much.
That concludes our conference for today. Thank you all our speakers and attendees for your participation. Thank you all.